Hi, I'm Dr. Jared Gardner, and I'm here today with my awesome dermatology residents, pathology residents, and dermpath fellows. And we are going to talk about metabolic and deposition diseases, which is kind of a group of different, not totally related entities, but stuff that deposits in the skin that's not supposed to be there. So let's start with case one. Who'd like to take this one?
I can do this one.
Okay.
So just looking at the low power, we see there's this big empty spaces in the dermis, and almost gives the collagen like a cracked appearance with maybe some eosinophilic deposition in there. My first thought on this was like, the cracked spaces almost made me think of like colloid milium or amyloid, one of those. But I can also see that the deposition is around eccrine glands mostly, or the eccrine glands are kind of trapped there. So that makes me think more of lipoid proteinosis, but I think clinical information would be very helpful in this case.
Good. So what kind of clinical presentation does lipoid proteinosis have?
Yeah, it looks almost like amyloid deposition, but it's usually around the eyes. That's one of the common locations.
And I think there's like larynx and pharyngeal involvement also. But I was just, for those online viewers, I was telling my residents right before we started that I had to look this up because this is one of those diseases, and there will be several of them in this episode, that I can never keep straight in my head because, number one, to my knowledge, I've never seen a real-life case of lipoid proteinosis. It's rare. It's autosomal recessive to my recollection. And what is the protein that deposits? Do any of you guys remember? There's like a gene that's known because it's autosomal recessive, but I can't remember the protein. It's like...
Yeah, it's the extracellular matrix protein 1.
Okay,
ECM1.
ECM1. And so it's interesting because it, to me, like you mentioned, it looks a lot like amyloid. It's pink, it's homogeneous or hyalinized. Hyalos is the Greek word for glass, and so glassy, we use that word a lot in pathology. Hyalinized or glassy. It means like kind of smudgy and even looking, and has the pink and has cracks between it, right? So if you show me this, my first thought is going to be amyloidosis, okay? And I think in real life, that is exactly what I'd do. If I had a case like this, I would try, I like thioflavin T as a stain for amyloid. I think it in my laboratory works better than Congo red. This material, in lipoid proteinosis, does stain weakly at least with Congo red and thioflavin T. But I would say that's kind of the problem is that, amyloid doesn't always have, the books teach you apple green birefringence on Congo. In real life, unless you have a real bright microscope and a really high-performing Congo red stain in your lab, I think it's a lot more challenging to get Congo red to work that way in real life. So weak versus strong, I mean, that's kind of one of those things that's nice to memorize for tests, but in real life, it's harder to sort this stuff out, I think. So if I had this in real life, what I would honestly do is, yes, get clinical information, but also I would send this out for mass spectrometry. So mass spec is a great way to subtype amyloid. So when I see something that is definitely amyloid, I usually send it for mass spec to determine if it's light chain or AL type amyloid, which has a higher risk of having a systemic involvement, like systemic amyloidosis, or some other type of amyloid, or something that's not amyloid actually. And it's interesting because I have had cases of amyloidosis, like it was to my recollection, what was it? It was amyloidosis in like a synovium in an elderly woman who had like a hip replacement, and I happened to notice some little nodules of amyloid underneath the synovium, which I thought was kind of odd. And I sent it out for mass spec, and you know what it came back as? It came back as extracellular matrix, ECM, but it wasn't ECM1, it was a different number, and it was something I had never heard of before, but it had been associated with amyloid deposits in elderly females, not usually associated with systemic disease. So all these unusual depositions of proteins can give us this similar amyloid-like appearance. So I think that's really, to me, it's interesting because there's like a link then, right? Something that was amyloid and is a type of amyloid that showed up elsewhere in the body, not in the skin, but it was also a different type of extracellular matrix protein. But like you said, the way that lipoid proteinosis starts is that you get deposits of this pink material, which I think the name lipoid proteinosis, at least according to the McKee derm textbook, is that there is some lipid, there was thought to be some lipid component to the deposition, at least at one point in time. So, and that's where I think lipoid got into the name. Because otherwise, lipoid, I would never have looked at this and thought that lipoid would be a fitting name for this. So it starts as pink homogeneous deposits around capillaries and around eccrine coils. Right down here, like you nicely pointed out, we can see that beautifully depositing there. But I'll tell you, amyloidosis, light chain amyloid, can deposit around eccrine coils and around vessels too. So I would send this out for mass spec in real life. I would also do Congo and thioflavin first, of course. And then I think you brought up a good differential as well, is colloid milium, which is another one of those diseases I can't remember because A, I rarely see it, and B, it looks a lot like amyloidosis. It has homogeneous stuff in cracks. It looks, my understanding there is that it's a deposit of different proteins that are somewhat related to solar elastosis. If memory serves, it's been a little while since I read about it. And it's another one of those things that I think I've maybe seen 1 or 2 cases in real life, but the last time I thought, this is going to be a good example of colloid milium, and I sent it out for mass spec, and guess what it came back as? Light chain amyloid. It was not colloid milium, it was amyloidosis. So, just so you know, you can read the little clues in the books, but I'll tell you in real life, thankfully, we have some technology that can be done. For anyone watching this online, I send my mass spec to Mayo Clinic. I have no financial conflict of interest. I've been really happy with the work they do. I send the tissue block there. They give a nice report and tell they look for amyloid, and if they find amyloid or another deposit that they think can be dissected out, they'll dissect out that part of the tissue, and they do mass spec, which is this crazy technology, for anyone who doesn't know, that breaks apart the molecules into tiny little bits and lets them fly through this like chamber, and where the particles land tells what the molecular weight is. This is my super non-scientific explanation because, frankly, the physics of it is mind-boggling, and I don't know how people ever figured this out. This is what really smart folks do. For me, I'll stick with pathology. All right, that's lipoid proteinosis. If anyone out there is watching this and has a better knowledge for me about how to diagnose this versus amyloid, please leave a comment down below. Thank you very much.
Does plasma cell help to differentiate this entity?
Does what? I'm sorry?
Plasma cell.
Plasma cells. That's a great question. So plasma cells in amyloidosis. So there are two, when we have light chain amyloid deposits in the skin that make like either perivascular or a nodule of amyloid that's light chain, there are 2 different main situations that we can have. One is systemic amyloidosis involving the skin, okay? In that situation, someone will usually have a clonal plasma cell process elsewhere in their body, like in their bone marrow or circulating plasma cells, and they may or may not have any plasma cells localized in the skin. The other situation is called nodular amyloidosis. I don't really love this name because nodular amyloidosis, it sounds like it means, you call it that when there's a nodule, but guess what? Systemic amyloidosis can produce nodular aggregates of amyloid in the skin. So the difference is that nodular amyloidosis, by definition, is light chain, AL, type amyloid, deposited in the skin by clonal plasma cells, but the plasma cells are limited to the skin only, and they're not present systemically. So it is a diagnosis of exclusion. If someone has plasma cells that are there in the skin and AL type amyloid, then they must have clinical workup, usually a bone marrow biopsy. They may do some other types of imaging to check their heart and other things for involvement. And if they've excluded systemic disease, then you can call it nodular amyloid, which basically is cutaneous limited AL type amyloidosis. And a subset of those patients will then later progress to systemic amyloidosis based on what I've read. So anytime I get AL light chain type amyloid in the skin, it is useful if you see plasma cells around there to think, maybe this is one of those nodular amyloid cases that's limited to the skin, but they still must get clinical workup to exclude systemic involvement. So that's a great question. So you don't always have plasma cells present in the skin, but if you do, that is a good clue for amyloid and could potentially be the skin limited type of nodular AL type amyloid. Great question. All right.
Thank you.
What is going on here? Case 2, this beautiful example.
I'll take this on, Dr. Gardner. Okay, so this looks like a little punch. From here, I'm wondering if it's mucosal because the epidermis is a little acanthotic and maybe even a little glycogenated.
Very good.
And then, of course, there's this large, like, pseudocyst type picture in the dermis.
Yep.
And then you're seeing what I believe are little salivary glands off to the side. And yeah.
Very good.
And if we go in a little bit on that cystic structure, yeah, it looks like what I typically see with a mucosole with like the little mucophages kind of eating up the mucus in there. So I would say mucocele.
Yeah, exactly. This is a mucocele of the lip, okay? Also sometimes referred to as mucus extravasation phenomenon. And the idea is that one of the minor salivary gland ducts gets blocked or ruptures and leaves a pocket or pool of mucus, mucoid salivary secretion, in the submucosal connective tissue. And then that gets usually surrounded by a variable amount of histiocytes, macrophages that are eating up that mucus, and we could call those muciphages. And it's exactly like you described. We know that we're in mucosa because it looks like skin, like epidermis, but it's lacking a granular layer. It's lacking a stratum corneum. Usually, if it gets irritated, you can get some granular stuff a little bit, and you can get some parakeratosis over it. But in general, squamous mucosa has stratified squamous, but doesn't have the stratum corneum or granular layer on top, and it often has pale, glycogen-filled, kind of clear-looking keratinocytes. Don't mistake these for koilocytes, okay? Not everything that has a vacuole is a koilocyte, just in case anyone out there is thinking that. All right, this is normal for squamous mucosa. So if you just had this could be oral cavity, it could be the vermilion or the mucosal area of the lip, it could be vaginal mucosa, it could be anal mucosa, all right? It could be esophageal mucosa. It all looks the same. So, to me at least. So the difference down here also that we can see that tells us we're in the lip, we've got skeletal muscle, which is helpful. And we've got minor salivary gland. And minor salivary glands are little clusters of glands, and they are composed of mucoid cells. They're cells that are like goblet cells, right? They're filled with mucin. Depending on this is a little bit slightly faded slide, but it can look somewhere between clear and pale blue. The pale blue of mucin tends to be the first thing I think to fade out in slides as on H&E as the slide ages. So thankfully, as we start getting better at scanning things, as soon as we get them cut, this problem will hopefully become a thing of the past. You can see it's a little bit bluish here, and that blue there, of course, is ink. So that's minor salivary glands are small. They're in the oral mucosa, and they're completely mucinous, as opposed to the parotid gland, out on the cheek, is going to be completely composed of serous type little lobules of serous cells, which have granules in their cytoplasm and don't have these cleared out mucus-filled glands. Okay, and then the submandibular gland is a mixture of serous and mucus, and the sublingual is larger than this, but fully mucinous or goblet cell filled. All right, so anyway, then in the middle of the cyst, you will see mucin, maybe. Sometimes it washes out during processing, and so you won't have any of this. But if you're lucky, you'll get some of that there, and you'll get these foamy cells. But say we just had a biopsy like this from the lip, and there's like a little kind of translucent bump on the lip, is often what these look like, a little papule on the lip, slightly compressible. Sometimes you'll just get the top of it, and so you'll just see mucosa, and then down here the little edge of the pseudocyst that's lined not by epithelium but by a collection of histiocytes with a slightly frothy, foamy cytoplasm. They look a lot like xanthomatous cells to me. Except in xanthoma, like true foamy cells that have eaten up lipid, they tend to be bubbles that indent the nucleus more than this. Also, if you wanted to, you could do a mucin stain here, like a colloidal iron or something to highlight them, but you really don't need to. But that's a nice example of mucocele or mucus extravasation phenomenon, and really nice when you get the entire specimen here removed. You can see all of it. Case 3.
I can do this one. So we're looking at 2 shaves, I think, unless they're just shallow punches here.
I think shallow punches probably, but it's hard to tell sometimes. You're right.
Yeah. From further out, I feel like the dermis is like a little bit busy, kind of approaching the epidermis, but not seeing a ton.
I think that's mostly here just like solar elastosis that's kind of dark on this stain. They've got a lot of sun damage there. Okay.
And then as we're coming in, there's kind of this like unnatural color to a lot of like the vessels and glands where it looks like dark almost like on the rim. And then, yeah, when we're zooming in, you can kind of see these small, like, black granules.
Gosh.
Yeah, sorry, there's a lag on my end, so sorry if I'm not describing.
No, there's a lag here too. I was wondering, I meant to preview this slide specifically to see, like, is it possible to see this on this scan? And the answer is not really great.
Really.
There are, like you said, this is one of those things, if you don't know what you're looking for based on the clinical, you will easily look right past this, because this, to me, looks at low power like normal skin for an older sun damage patient. The abnormality here is that they have sun damage, but for an older person, that's their normal skin for somebody who's old and has sun damage. Got a little epidermal atrophy with solar elastosis. But here, the patient's probably described as having a slightly bluish gray tinge to their skin, right? Or maybe a very blue look to the skin. Some people have, been described as having a Smurf-like appearance, which I don't think is really necessarily politically correct or nice to say, but in case you've heard of that and you're watching this online, that's a term that's been used for people with this condition. And when you look closer, you will find little black or darkly colored granules, usually rimming around the outside of the eccrine coil. So I'll try to find a good picture of this and insert here in the video later for the people who are online, so you can see this properly. Maybe I can pull this slide from the set. That's with those little tiny specks here and dots around the outside, and those are metal deposits. They are silver deposits. So what is this called? Argyria. And Argyria is silver deposition in the skin. And in the olden days, it was described, I think, in people that were like silver miners and that worked in silver mines and inhaled dust particles that had silver in it. And we don't, at least in our area, don't think we have any silver mines here. But the times that we do tend to see this in more modern days is that people drink colloidal silver, and if you consume large quantities of that, you can develop Argyria, and that's because some people believe there are some health benefits of colloidal silver. I have not read anything scientific that has convinced me of that, but I'm sure someone online will argue with me about it. But the problem is that if you do this long enough, it will eventually deposit in your skin, and these little silver particles will make your skin have a blue-gray appearance. And if you're watching this, you can Google Argyria, and you will see some dramatic pictures in the Google image search of people with Argyria. And I have seen one person at like a farmer's market in real life, like from across the street. I was like, whoa, Argyria. Either that, or there are some drugs that can produce pigment deposition in the dermis that give you that same blue or slate gray appearance of the skin. And unfortunately, to my knowledge, it's pretty much unreversible. There may be some sort of treatments that are out there to try to diminish it, but once these metal deposits are there, they're not going away, basically. So if you are someone who consumes large quantities of colloidal silver, you may want to, at least do some research on that and keep in mind that Argyria is a side effect you may not desire. So yes, the little deposits are there. And in general, metal particles in the skin will look like little black dots. They're because the light doesn't pass through them, so they look very, very dark. Or I think on this scan they're kind of looking almost brown color, but they're kind of a brownish to black, slightly refractile sometimes. Deposits. Gold can have a similar appearance. I don't think I've ever seen a case of gold deposition, but in the 70s or the 80s, people took gold-based drugs for like rheumatoid arthritis. I took gold for a while. I remember that as a kid thinking that was kind of wild. Before the age of biologics, there were some drugs like that. I'm not sure if gold drugs are still used at all anymore, but it's something that can give you a similar appearance to Argyria. So that's Argyria silver deposition. Very rare to encounter in my practice, at least. All right. Case 4.
You can go on this one. Kind of within epi there, you're seeing like a large chunk of this purple material, so probably calcium.
Good.
So this is good for really just kind of calcinosis or subepidermal calcified nodule.
Yeah, exactly.
Really.
This is a subepidermal calcified nodule, which to me is just kind of like a name for a kind of, I think of it as a subtype of calcinosis cutis. It's calcification deposited in the skin, but generally, I've only seen a handful of cases in real life. But the time I think of it is like usually in like around the eyelid, on a kid, solitary lesion. On biopsy, it's a nodular aggregate of kind of chunky calcium deposits in the dermis right beneath the epidermis. And is an incidental finding. To my knowledge, there's no association with any systemic calcium or phosphate abnormalities. So it basically, I think of it as kind of like a localized form of calcinosis cutis that's just an incidental solitary lesion. And it's usually, like I said, in kids, and the eyelid, I think, is the more common site. I'm not sure here. I doubt this is eyelid based on the punch here. I would have voted this is probably acral skin, although it's got a lot of reactive epidermal hyperplasia and kind of lichen simplex chronicus changes over it. So it's hard to know if it's that or if it's just been picked at a bit. But yeah, that's subepidermal calcified nodule, which again I think of as kind of a variation of calcinosis cutis. Case 5.
I can do this one. So it looks like from here in like the superficial dermis, there are some like brown, like yellow-brown structures, and like the shape of them you can think like looks like bananas.
Yep.
So this one is good for ochronosis.
Yeah, once you've seen this, like, I mean, this is the thing, right? Like, I don't think anything else really looks like this. Ochronosis gives you this yellowish, brown, kind of appearance. I think, if I recall, the name comes from ochre, which is like a pigment that's got a yellowish brown color used in paint production. And the only reason I remember it is because as a kid, before Bob Ross, the painter with like the permed out hair from like the 70s and 80s, my grandparents would watch that, and at their house I would always watch Bob Ross, and he's like, we'll take some yellow ochre here and mix it together with titanium white or something like that, and then he'd paint a mountain or trees. And if you haven't watched Bob Ross, go and Google that. And thankfully he's had a resurgence posthumously, which is really cool, because I think he was such a happy, nice guy and always painting like happy trees and mountains. So if you want a little joy in your day, go watch a Bob Ross video and see some cool painting. And I guarantee you at some point you will hear the word ochre. But maybe that's all wrong, and that's not where the name for this entity came from, but I think I'm going to leave it in. But I think that I did hear that once. But anyway, ochronosis, you get these brownish yellow, banana-shaped things. And what this is basically, these are thickened, usually elastic fibers. I think collagen bundles can also get some deposition. And material is depositing on them. And you have two main situations where this pattern can arise. And what are those?
So it could either be with alkaptonuria, or it can be like the exogenous form, which can be from like multiple different medications. But I think most commonly with dermatology, we think of hydroquinone. Yeah,
exactly. Hydroquinone, which I think is used, is it, when people use it, don't they use it for skin lightening?
Yeah.
Like is it topical hydroquinone that does this?
Yeah.
Yeah, so topical hydroquinone can be, people try it for skin lightening, but then paradoxically can cause this deposit to accumulate, which then makes the skin have a dark appearance. I have another video I think that I've made about this in the past, and people have asked me, like, how do you treat this or make this go away? And I don't know. So if you're watching this, I'm sorry, because I know skin pigmentation issues can be a real problem for patients, and really, very morbid. So certainly it's an issue. So that's, like you said, exogenous ochronosis. And much more rare, at least in my experience, is when people have the genetic disease alkaptonuria, which is a homogenized acid oxidase deficiency. And they can have black or a darkly brown discolored urine, and then deposits of pigment in their skin on their elastic fibers, and sometimes the collagen bundles as well. And so microscopically, to my knowledge, they have the same appearance. You just have to put together whether they have the other features clinically that would support having the inherited genetic disease, or if they've been applying topical hydroquinone. So that is Ochronosis. And I don't see it very often, but it is quite cool to see microscopically because it's a very distinct appearance. Case 6. It's kind of a funny, twisted, tangential punch here.
I can take this one.
Okay, great.
So in this one, there is like the most prominent feature is this degeneration or ballooning of the upper epidermis. That is very striking in this one.
Yeah.
And otherwise, I don't see much inflammation going on, maybe a little bit non-specific.
Agree.
So this characteristic pattern of upper epidermal degeneration and ballooning is seen in like nutritional deficiency disorders.
Yeah, very good.
Dermatitis.
Very good. So yes, this is nutritional deficiency, and this one looks kind of funny. It looks like a polyp here. I think the degenerated epidermis is kind of like sloughed to the side a little bit, and then the specimen's tangentially embedded. So it looks like we're looking at a polyp here, but that's not really the case. It's just a punch biopsy where it's kind of been pinched out a little bit. So maybe not the best example, but yeah, the epidermis has like a slightly, maybe in some cases it'll be like kind of psoriasiform and acanthotic. Here it's actually kind of thin, but you get this pallor or pale kind of vacuolated appearance of the superficial spinous layer. And that pattern is characteristically seen in a few different conditions, which we kind of like lump together and say nutritional deficiency. This case was, I think, zinc deficiency, which is also known as acrodermatitis enteropathica, and clinically presents as kind of a psoriasiform erythematous eruption, often around orifices, so around the mouth, in the perianal and genital area. And then there are two other conditions that can have an essentially identical, and other vitamin deficiencies. I think like pellagra can also, like B vitamin deficiencies can also have a similar microscopic appearance. So we kind of lump that as zinc, and other nutritional deficiencies can look like this. And then two other things that can do this are necrolytic migratory erythema, which is a skin eruption that is seen in patients with metastatic glucagonoma, which is like a pancreatic neuroendocrine tumor that secretes glucagon. And when that's, I believe usually when it's metastatic, like to the liver, then the secretion of glucagon for some reason produces an eruption in the skin that also, for unknown reasons to me, has a very similar appearance to what you see in zinc deficiency. So the clinical scenario is different. And then also another entity, which I don't think I've ever actually seen in real life, is acral necrolytic erythema. Am I getting that right? I always get the order of those words confused with necrolytic migratory erythema. Can one of you guys tell me? Do you know?
Necrolytic acral erythema.
Necrolytic acral erythema. Yeah, I don't know if I've ever seen a real example of necrolytic acral erythema, but it is a psoriasiform eruption on the acral surfaces, like the feet and the hands, and is often associated with hepatitis C, but I don't know if it always is seen in hep C, but that's the classic kind of board's pearl that I remember. But all of those things can have this appearance. Now, I will tell you that I have seen a case of glucagonoma syndrome or necrolytic migratory erythema that did not really have any pallor. It just had kind of some psoriasiform change, but I can't remember. There was some like clinical thing where we brought that up and they looked up and the patient had undiagnosed glucagonoma, actually, which was crazy. That was years ago, but I remember that case because it didn't have the pallor. And then I've also seen quite a few times where I see some vague pallor on a skin biopsy for some sort of a rash, and it is not any of these conditions. So sometimes we see this finding non-specifically. But on a test, when you see this pale superficial spinous layer, the test answer should be one of the things we just discussed: nutritional deficiency, zinc deficiency, glucagonoma syndrome, or necrolytic acral erythema. All right, good job.
Dr. Gardner, can there be any changes specifically in the stratum corneum also?
I don't know. I don't know what the stratum corneum is supposed to show. Actually, I can't remember what the classic answer is supposed to be. I feel like I have remembered seeing some examples in study sets that had parakeratosis more, whereas here we have ortho. But it's possible that I'm remembering that incorrectly. I don't know. Do any of you guys know?
No, you are right for the literature. It can show parakeratosis.
But yeah, here we have very little, right? Maybe a little para, but it kind of looks more ortho. So.
Yep.
Yeah, the one that we just had, it was like a broad band of parakeratosis, and then orthokeratosis overlying it, and then there was just like very focal foci of epidermal pallor. But it
Wow.
was like very distinct. That like, I guess that like broad band of parakeratosis is fairly characteristic.
Interesting. So that's, and you know, and when I see changes that make me think of this, especially if I have limited clinical info or if there's any doubt, like, could this be nutritional or one of those entities? I'll sometimes put a comment, like, there's some pallor, it may be non-specific, but, you know, it can be, this finding could be seen in these conditions, you know, zinc and nutritional deficiencies and other related entities. I generally kind of word it that way because my dermatology colleagues know what the other entities are, and I don't want a patient to read that report and go thinking that they have metastatic glucagonoma or something really bad like that, when most likely they do not. So that's the way I've kind of handled that in my practice. I'm not sure if that's the best way or the right way, but that way at least it can be on the radar for the dermatologist or other treating physician to, you know, at least consider, is there any chance that this person might have a nutritional problem or something else that they need worked up for, especially if the process persists and they don't get it better. But I have seen it non-specifically in psoriasiform, you know, eruption, psoriasis, psoriasiform drug eruption, spongiotic dermatitis. Sometimes you can see this kind of pale look to the epidermis that resembles this. And also, like here, kind of, you could think also a little of like the ballooning changes that you see like in hand, foot, mouth disease. Although in that, you're usually going to have dermal edema, which we have some edema here, but dermal hemorrhage, dermal lymphocytic infiltrate. But this case, because it's kind of pouched out like this, it kind of also could remind you a little of hand, foot, mouth, maybe. So there you go. That's the differential there. All right, case 7.
So sort of from this power, sort of busy dermis.
Busy dermis, good. It's a good thing, I think, to pick up if you're watching this at home, is when you look at skin from low power and it seems like epidermis looks kind of normal, not a lot of inflammation, but the dermis has like kind of too many cells. That's a subtle feature that I think takes some time. If you're just starting dermpath and you have trouble with entities like that, you're not alone. I think like recognizing changes in dermal collagen or subtle changes in dermal cellularity is a nuanced skill that is not easy to pick up when you first start doing dermpath. But I think it's nicely demonstrated here because look, this is normal derms. Ignore the blood. The blood's just from the punch biopsy from the procedure. Normal dermal collagen, pretty much, with about normal amount of scattered fibroblasts in here and maybe some rare lymphocytes and mast cells and stuff, the usual things. And then up here, not normal dermis. It's got the collagen texture is different. It's got an increased cellularity. So that's kind of the difference. And that's how you can begin to compare normal with abnormal. But when you only have abnormal on a biopsy and it's subtle, it can be really hard to tell it apart from normal dermis until you have some experience looking at a lot of skin biopsies. All right. Sorry, Kayla. Go, please proceed.
No, it's all right. And then, so we kind of increase in interstitial sort of spindled cells, and then even from this power, you're kind of picking up on interstitial mucin.
Yeah.
So it would be good for scleromyx.
Yeah, so Scleromyxedema. This is something I've only seen a couple of times in real life. It's rare. I think it's easy to miss this entity if you're not thinking of it. This example is kind of nice because there is kind of a bluish myxoid mucin in here, but also I think some of the blue we're getting here is from some solar elastosis kind of mingled in with this, which makes it look a little almost too good to be true. I have another video of this and some other posts about it online, so if you're watching this, and you can go look up like on my Kiko index and see some other examples. But I would say that a couple times I've seen this in real life, and as well as at meetings, when I see Scleromyxedema, I'll tell you two things. The name says mix, like it should be myxoid, blue, myxoid, and mucin. I use as kind of interchangeable terms for that blue, glycosaminoglycan ground substance that's deposited in the dermis. I would say that oftentimes the cases I've seen did not really look very myxoid to me. They didn't really look very blue on H&E stain. So I think this case looks almost, like I said, too good to be true because it's got some elastosis in there. But if you do like colloidal iron or alcium blue, like a myxoid stain, it can kind of help highlight that. Although I think those stains can be a little tricky to interpret. The other thing is that some of the cases I've seen were a lot more cellular and spindly than this, and almost made me think of like a dermatofibroma or something. So, but then clinically they didn't really fit for that. So if you see something that looks kind of like a dermatofibroma with subtle myxoid change, think about Scleromyxedema. At least that's worked for me. Because dermatofibromas, for some strange reason, even though they have like 35 different morphologic variants, I just made that number up. I don't know how many, but there are so many different patterns but myxoid is not really one of them. I've seen, I don't know, thousands of dermatofibromas probably, and you'll almost never see myxoid change, which is weird because like every other soft tissue tumor under the sun, if it's a spindle cell tumor, it's a good chance there's a myxoid variant of it, but not DF. I don't know why that is. All right, so in any case, you get this subtle increase or more prominent increase in spindled kind of fibroblasts and the kind of change in the dermal collagen texture with subtle mucin or myxoid material mixed in there, intermingled. Let's see, I think, do we have a slide of the colloidal iron? I believe we do. And if you're not familiar with this, colloidal iron stain uses iron in the staining process, but it is not a stain for iron. So it's not an iron stain like a Gomori iron, which is going to turn iron or hemosiderin blue. This is a stain that does nothing to do with detecting iron, but actually it's a stain used for detecting ground substance, hyaluronic acid, mucin, myxoid material, whatever word you like. And here you can actually see much more prominently, this one worked beautifully actually, that there's a lot of increased interstitial myxoid or mucin deposition in between those spindle cells. So that's scleromyxedema in the proper clinical setting. So what is the clinical setting for scleromyxedema?
You can see it with like IUG, lambda paraproteinemia.
Right, it's often associated with paraproteins, and so these patients need workup for other systemic abnormalities. And what's the clinical appearance of it?
Kind of like this linear waxy papules, plaques, sometimes on the face also.
Good. Waxy papules and plaques. And then there's also kind of the papular form of it can also be called, what is it? Is it lichen myxodermatosis? Is that correct? Did I get that correct?
And papular mucinosis.
Papular mucinosis. It's like, nothing in dermpath or dermatology can have just one name, right? It's got to have many names. So papular mucinosis and lichen myxodermatosis, both synonyms for scleromyxedema, correct? I got that right? Okay, good. So, and then the other two entities that sound like this but don't look like this are scleroedema, which is going to have a normal amount of spindle cells in the dermis and just have increased interstitial myxoid mucin deposition. So it look blue but not have the increased cellularity that we saw in the last slide. And then pretibial myxedema, which is going to have tons of mucin and low cellularity, and the mucin is going to be like replacing the collagen, and it's usually going to be on the shins in patients with Graves' disease oftentimes. So, and in those cases, usually you don't need a colloidal iron or anything. The mucin is obvious on H&E. So I've got a little post in another video that talks about those. Those are three like dermpath name-alikes that don't really look alike. Scleroedema, scleromyxedema, and pretibial myxedema. They all sound a lot alike, but they really look different most of the time. So you can go and check that other video out. I'll try to put a link down below.
Nephrogenic systemic fibrosis.
Very
being a mimic
good.
histologically.
I'm glad you brought that up. Thank you. Nephrogenic systemic fibrosis, NSF. Which is associated with deposition of gadolinium contrast agents in the skin, and it causes a appearance that, to my eye, looks essentially identical to scleromyxedema. If there's a way, I don't know, how are you guys taught to tell those two apart on Path?
Is clinically.
Yeah, I was going to say, to me, I don't know without the clinical history, and I don't know what the difference is. But I feel like this is something that is like a vanishing entity, like because they changed the way they do the contrast or how much contrast they put in. Because I think gadolinium is still used, correct?
I think they're just checking kidney function.
Oh, to make sure that they don't give it to patients that have significantly impaired renal function. Yeah, so when people have, and I know I've heard radiologists debate about this, about when it's appropriate to use gadolinium, and I don't know what the rules are on that, but there is a point where someone, if they have bad enough renal function, the gadolinium may not clear out of their body and instead deposits in their skin, and I think also in their joints, and it can cause joint mobility issues and other problems. And so they can do like X-ray crystallography, I think is what it is, right? Where they can actually find the gadolinium in the skin. That's how this was first discovered. And my friend Whitney High, he's a dermatopathologist and brilliant guy, who practices in Colorado. I think he did some of maybe the first or some of the very first landmark papers about gadolinium deposition in nephrogenic systemic fibrosis. So on tests, remember that NSF and scleromyxedema look alike, but their clinical differences in the history is key. I don't know how to tell them apart microscopically otherwise.
I remember some people mentioned NSF may be deeper of the fibroblasts with the mucin into the dermis.
Oh,
but
that
I don't
it
know
goes.
whether it is true or not.
Ah, interesting. That's good. Good point. I've seen like one slide of it, like in a study set, but I've never seen a real life case to my knowledge. So that maybe NSF goes deeper. Cool. That's one of those. It's like I've learned about and I've read about, but it's hard to kind of learn the nuances when you never see these things. So that's a lot of the things we're talking about today are really rare that I do not encounter in my practice. All right, case 9.
I can take this one. This is a square punch, really deep punch. And we can see some inflammation cell, but it seems to be loose the fibroblast histiocyte in the dermis. And then the collagen bundle really thick.
Good.
And then the nexal structure, especially the eccrine gland, they lose kind of the fat, maybe, and some also lose hair follicle. So it could be Morphea.
Very good. Yeah. So from low power, people sometimes say this is the square, or I guess more likely rectangle punch biopsy sign, that the punch has this like very like perfectly squared off look at the top, like the epidermis goes across and then it's straight down, and that's because the dermis is so densely packed with the more dense than usual collagen, and so then that's a good clue for Morphea. And so what Morphea is it's localized, like a localized form of scleroderma, right? So in some patients get a similar appearance who have actually like systemic sclerosis or a systemic form of scleroderma, but then other people get this localized cutaneous form that we call Morphea, and it often presents as kind of like a firm, kind of depressed, indurated plaque on the trunk, and sometimes has a kind of slightly purple violaceous look clinically. Other times it can have a linear appearance, and particularly on the forehead where it's been called un coup de sable. I'm sorry for my French-speaking listeners for my poor pronunciation. I have a hard time with the French R and basically all the other French sounds. But un coup de sabre, which is like the cut of the saber, supposedly. So it's this linear appearance that looks like you kind of have like a linear scar on the forehead. So those are the signs for Morphea clinically. Microscopically, Morphea can be hard to diagnose because it looks, if you ignore some of the clues, it can kind of look a lot like the normal dermis, right? If you take a punch biopsy from the back or the abdomen, the normal skin of the trunk, the dermis looks kind of similar to Morphea at first glance. This is another one of those when the entire dermis is abnormal in its collagen pattern or collagen density, it's hard to tell that it's abnormal unless you have some normal next to it, and then you're like, oh yeah, this is definitely thicker, more densely packed collagen bundles. The bundles of collagen get kind of thicker and they get packed closely together and don't have as much white space between them, but sometimes you can kind of see a similar look to that artifactually, just depending on how the biopsy gets processed and how it looks. So just be aware of that sometimes you'll think, ooh, this could be Morphea, and I think it's like a classic trick on exams where it's actually just normal back skin. But some of the clues, like you said, Li Ping, an infiltrate of lymphocytes and plasma cells can be really helpful, especially in the early kind of inflammatory phase of Morphea. A lot of times, too, as Morphea progresses, you'll get real dense sclerosis in the collagen up here, and the deeper dermal collagen early on sometimes looks more normal. So sometimes you'll get kind of an interface between dense sclerosis and then kind of more normal collagen, and there tends to be more lymphocytes and plasma cells kind of near the border of that advancing edge of sclerosis. We do not see that here. It's kind of more patchy and perivascular inflammation here. Other things to keep in mind that can kind of give you this appearance is erythema chronica migrans or Lyme's disease. Lyme disease can have an infiltrate of lymphocytes and plasma cells and can have some sclerotic collagen in the dermis. And, you can also think of syphilis. I don't usually think of it as causing sclerosis of the dermis, but perivascular with lymphs and plasma cells, think about syphilis, think about tumid lupus. Those could be other things that you could put in your differential. But here, the sclerotic collagen is really dense and really nice and well developed in this case. Classically in Morphea, the papillary dermis is spared. So the papillary dermis here still has, if it comes into focus here, very fine, delicate collagen fibers, very wispy. It's hard to appreciate on a scan, but if you go and look at normal dermis versus, say, someone with a really chronic eczematous dermatitis or lichen simplex chronicus that's been scratched and rubbed, if you go and look, the dermal collagen in the papillary dermis is very fine and delicate normally, like we see here, and then the reticular dermis is big, thick bundles of collagen. Like I said, collagen patterns are hard to pick up on, so it takes practice. So it's practice on normal skin. Find someone who's got normal skin, you know, on a melanoma excision specimen or something like that, or a nevus excised from a young person. Go look at the skin out on the side to see what normal papillary dermis, normal reticular dermis look like. I also have a skin histology video. If you're watching this online, you can go and look at that, and it talks at length about that. Whereas other things like chronic reactive things begin to make dense, thicker collagen bundles in the papillary dermis. The reason I'm bringing this up is that there's another entity that can overlap with Morphea, and that is lichen sclerosus atrophicus, and LSA, lichen sclerosus, hyalinizes and makes sclerotic collagen in the papillary dermis, but tends to spare the deeper reticular dermis. And then there is such an entity as lichen sclerosus / Morphea overlap, where you get hyalinization of you get lichen sclerosus changes up top, and Morphea changes down below. So anyway, just so you know, those are some things that you could need to know about in your differential. And I like that you pointed out what happens over time is that the fat that normally exists around the eccrine coils begins to get squished out, and eventually the eccrine coils are gone. Now here, there's still some residual fat, so it's not totally removed them, but look at, this is a pretty big piece of skin, and there's like almost no adnexal structure here. There's one eccrine coil and one or two little hair follicles that are hanging on for dear, or just one hair follicle, or maybe that's an eccrine duct, I can't tell from here, that's hanging on for dear life. And in here, I think we had a little bit of eccrine coil that's been crushed to death by this advancing sclerotic collagen. So in well-developed Morphea, you'll see that. You'll see this kind of strangulation and compression and crushing of the fat, and then eventually the coil itself, and also the hair follicles, and eventually you'll get just dense sclerotic collagen with no residual adnexal structures if it's really well developed. If you have plasma cells present, that's a good sign that probably it's a localized form of scleroderma. It's Morphea. But the other thing is, I think if there's not good clinical info, it's important to point out that systemic sclerosis can have a very similar appearance microscopically to Morphea. So if there's any clinical concern, they need to do further workup for the patient, because that comes with a lot of different clinical abnormalities. All right.
This one was actually a little bit hard for me to figure out where exactly the pathology was. So on this one, all I saw was like blood. You can see there extravasated RBCs. You know, looked like there may be some pathology in the fat. But on the next one, the specimen to the left, it was actually more clear to me.
Yeah, there's definitely fibrosis and sclerosis of the fiber septa in between the fat lobules, right? So, right. But otherwise, it's hard to know why that's happening until we find.
Yeah, then we see this one blood vessel in the deep fat there, which has like these needle-shaped crystals. If it was just in the adipocytes, I was thinking like, oh, this looks like subcutaneous fat necrosis of the newborn.
Good point.
This is inside the vessel, so I think this is good for oxalosis.
Very good. So you get these refractile crystals, and when you use a polarizer, they have this like rainbow pattern of birefringence. It's very, very beautiful to look at. I don't think I've ever diagnosed a case of this in real life. I've just seen it. Other people I've worked with have diagnosed, but I've never had one come across my scope where I've recognized it up front that I know of. And so what kind of situations can cause cutaneous oxalosis?
So probably most commonly it's secondary oxalosis, which would be like seen with renal disease or like ethylene glycol poisoning.
Good.
That kind of stuff. And then there's also a genetic condition with autosomal recessive where you produce more oxalate in the serum.
Excellent. So yes, the patients need further workup. I always think of it as like ethylene glycol or antifreeze, poisoning, either intentional or accidental. But yeah, there are other conditions as well. So let me see. I think I've got an example here that is better that you will enjoy. So, see, did I disappoint? This is the best ever, right? Look at that. It's amazing. And they kind of have like a floret-like appearance here to me. And so I took many pictures. It's hard to get pictures of polarized light exam. It depends how you adjust the light and the polarizer. That's what it looked like here on H&E. These kind of, they're like radial arrays of kind of chunky needle-shaped crystals. Even though we say needle-shaped, they don't look really like gout to me at all. The way they're arranged together doesn't look like gout. And also, they, as far as I know, they survive the normal H&E staining process, and gout is usually mostly dissolved during that process. So those are nice examples. There's the H&E. This one, like I said, had just tons and tons of oxalate, and I can't remember what the clinical scenario was here. And there was extensive inflammation in the background skin, but this was through a teaching slide exchange that I was in that I got, so I don't remember what the clinical was. So there's a oxalosis, and here's a more subtle example. Okay, case 10.
Okay, I think I'm up here. So we have a punch biopsy, highlighting a little bit of hyperkeratosis, some pigment in the basilar layer there, so maybe a darker skin patient. And then looking at the dermis, to me there seems to be some like spaces in the dermis, and as we go closer, I am trying to look for what I think, you know, if there's spaces, I think maybe there's mucin in there. I think it's a little bit hard. Well, I think you can see it, but it's not quite as obvious as I've seen in other.
It's a faded slide. Like I said, the mucin, like on H&E, the subtle blue of mucin fades out really quickly, like in I don't know, less than a year. It's really kind of sad. You get this beautiful recut for teaching, and then a year from now, it's already fading. But and then it's worse also, like we're projecting it and we're looking at a digital slide where the light can. It's also hard to take pictures of mucin sometimes because it can wash out because of the white balancing. So I find it challenging. But if you can see, here's white space. That this is like artifactual white space where like the collagen's kind of separated from adjacent. But then in between this kind of grainy light blue stuff, that's mucin or myxoid material, hyaluronic acid, right? So good. Most importantly, you can tell that the pink collagen bundles, which should be like close to each other, are way separated apart. So you know there's something there, either edema or mucin/myxoid material separating out the collagen bundles, right? This is way more than just artifact alone would allow. So good. So then, you know, much of the dermis is, instead of being pink, it's like pale blue that's dividing the pink out. So what is this?
So this, I think because it has a lot of mucin and it's not hypercellular like you were talking about before, it's probably pretibial myxedema.
Very good. This is like classic for pretibial myxedema, also known as thyroid dermopathy, is usually associated with hyperthyroidism, Graves' disease. Sometimes can be the presenting sign of Graves. I've seen, I think 2 times in practice where diagnosing this, that they did not know that the patient had Graves, and when we told them, they worked the patient up, and the patient had Graves. It classically presents as kind of thickened, like I think it is like kind of an orangish kind of color. I don't know, how is it classically described in books to you guys clinically? Anyone know?
I don't know if it says a particular color. The ones I've seen are more like skin colored.
Okay.
But yeah.
So I may have been biased. There was one I saw that kind of had like a like slight orangey brown color to it, and so in my mind I always think of that case, but it may be wrong. And I did have one case that presented as erythematous nodules that looked very much like erythema nodosum clinically, rather than the thick. So usually kind of a thickened plaque on the bilateral shins. And then the patient often will have, will have Graves' disease, autoimmune hyperthyroidism. So, but yeah, there are other forms. There's also a very rare, like, elephantiasis-like form where the whole leg can get kind of expanded. And then there is another form, which I did not know until I encountered this, where it can just be a few nodules. And clinically, I think I've seen that twice where we had cases that were nodular, and clinically, 2 good dermatologists that had not thought of the diagnosis because it didn't look classic. It was this uncommon nodular form, and they thought of paniculitis both times. And I think maybe those were both the cases where the one time they did not know the patient had Graves until they worked her up. And the other time the patient did have a history of Graves, but it had not been brought up to the dermatologist. It was like a distant history. So, yeah. So those are important to know, that it can sometimes present in a non-classic way, but it's usually on the shins, but sometimes other parts of the body can get this in patients with Graves' disease. All right. And so I have also seen several times where you get this pattern of epidermal kind of acanthosis and hyperplasia with hyperpigmentation of the basal layer, kind of like almost like an epidermal induction, like you'd see over dermatofibroma. So I think this, in this case, probably is reactive. I don't know what the patient's skin type was, but I have seen this multiple times in pretibial myxedema, where you get thickening, hyperplasia, or hypertrophy of the epidermis, and increased basal melanin production, which probably accounted for kind of the darker coloration I've seen. And so that's pretibial myxedema. And like we said, this is one that it's so much myxoid, you don't even need to do a colloidal iron stain. It's obvious if we had a good H&E here. And it doesn't have, it's way more myxoid than I've ever seen Scleromyxedema look like. And it doesn't have increased cellularity. It has the low, kind of normal number or even decreased number of fibroblasts in the dermis. So it's kind of like a sea of mucin that's pushing the collagen out of the way. So that is pretibial myxedema or thyroid dermopathy. This is case 11.
Yeah, I think it's back to me. So the first thing my eyes go to are the epidermis and how it's kind of effaced and the lots of reedy ridges there.
Good.
And then right below that pigment in the dermis that looks to be not natural. So I think if I were looking at this, I would zoom in on that. Otherwise, it looks relatively normal.
Except look what we have here. We have a little bonus finding here.
Oh yes, a little island of basaloid cells, probably a basal cell skin cancer. So kind of taking all of this into account of the effaced epidermis, that little fragment of basal cell tumor, this pigment is probably a biopsy site that hemostasis was achieved with Mucocele solution.
Very good. Yes. So here it's even better over here, where you can really see like some nice parallel fibroblasts, parallel to the epidermis, vertical vessels. So there's scar here. And then there's kind of some scale crust, and then the epidermis has regenerative changes here. So this is an excision specimen, and we are lucky here that we also get, like you said, there's a little island of basal cell carcinoma, which is another clue that this is an excision specimen. But without history, you might struggle here wondering what's going on. So, and I love that you pointed out right away, reedy are gone. So this atrophic epidermis without reedy, that's what the epidermis looks like as it regrows over a wound. And so that's another clue that there was a biopsy performed here. So we don't see this very often at all anymore, because most dermatologists that I've worked with do not use Mucocele solution. So Mucocele solution is ferric subsulfate, and it can be used after a biopsy to achieve hemostasis, as you said, to stop the bleeding. But the problem is that it can produce this pigment deposition of this iron pigment that looks a lot like hemosiderin. Can actually make a pigment that's seen clinically, so what's called a Mucocele's tattoo. So pretty much everyone that I work with, except that I've worked with a couple old school dermatologists in the past that still use Mucocele's, but everyone else I know uses aluminum chloride or Drysol, which has a different appearance microscopically, granular blue-gray histiocytes with little speckles in them and kind of purple calcified burned collagen fibers. So I don't know what the reason is why some people still use Mucocele's instead of aluminum chloride. I don't know if any of you guys ever heard of a reason for that. Does it achieve hemostasis better, or is it cheaper? Or is it just maybe a matter that people got used to doing it, and if you trained in a day where you did something, sometimes you stick with what you know? I've never heard a good argument for why there would be a reason to continue using Mucocele's rather than aluminum chloride, but
I think it traditionally does provide better hemostasis. It's just the staining that we try to avoid. So we do have it in clinic, and a couple of our nurses will take it out if there's a little bit of a bleeder on one of our biopsies, but yeah, in general, aluminum chloride.
That's good to know. So yeah, I have no financial interest. I don't even know who makes either of those products, but I always wondered because I almost never see this. And in fact, it's so rare that when I would see it on a specimen, I would know, oh, I know who biopsied this previously, even if I didn't see anything else in the case, because I only had like a couple derms that would use it. So in any case, the reason it's important is because A, we don't see it very often. And so if you've never encountered this, you will be bewildered the first time you see it. So how do we know it's not hemosiderin? Well, I'll tell you. When we see a biopsy site change, the granulation tissue that fills in the biopsy site and then turns into scar almost never has hemosiderin in it. And I think the reason for that, I've thought about that over time. No one ever taught me why this is, but I've looked at thousands and thousands of cases where there's biopsy site. And I was like, why don't we see hemosiderin? I think because what happened is a shave was done here. All this, a month or so ago, was air. It was scooped out and removed and was empty space. And then the granulation tissue, as it fills it in, any blood is on the surface and gets pushed up and kind of makes the scale crust or the scab over top, and gets pushed up and out of the skin, like we see happening here. All the crust on the top gets pushed up by the new granulation tissue, and then the granulation tissue, which doesn't have hemosiderin, it kind of fills in and produces a scar. So I feel like we often at a biopsy site, in scars from other reasons, you can see hemosiderin, but in biopsy site scars, I don't see much hemosiderin usually. Whereas here we see like, this would be like tons of hemosiderin overload, right? So the granulation tissue here is mixed with this stuff that looks just like hemosiderin, but there's so much of it. That's just not what we would see at a biopsy site change from regular bleeding, okay? The other thing that's important to note, is that Mucocele produces a really robust fibrohistiocytic kind of pattern. It makes lots of histiocytes and fibroblasts, so it tends to be much more cellular than regular granulation tissue that we would see like in an aluminum chloride treated biopsy site or a scar from other reasons. And the reason that's important is because I've seen this before on a melanoma excision where one of my trainees had looked at it and thought that it was actually melanoma because it was really quite spindly. And I can't remember if the patient had a spindle cell melanoma, so they thought spindle cells, there were some mitoses in it, there was brown pigment. Now, melanin and hemosiderin do look different. And again, I think to me, Mucocele's pigment itself looks to me identical to hemosiderin. Stains with iron stain. It'll stain like bright blue on an iron stain. It has a refractile kind of golden appearance, and like just like hemosiderin does. And melanin is more like a kind of fine powdery brown, not quite so golden orangey look. But in real life, I have been tricked before. Even as a dermpath, I've thought something would be melanin or hemosiderin and been wrong. So I think usually I'm pretty good at telling them apart, but every once in a while they can have overlapping appearance. So that's an important thing, is that you don't want to mistake this for actually like melanoma or a tumor, which here clearly it's not, but I have seen times where that happened. And I could see how it could happen because you can have mitotic activity in the granulation tissue and in the proliferating fibroblasts. So for some reason you get a more robust fibroblastic and histiocytic response to Mucocele. And so it can look a lot more cellular and kind of scary in some cases. So just something to be aware of because we don't encounter it very often anymore. So I think it's not on people's radar. And I only see it occasionally. The day that I get all the cases done, before 9 o'clock, I won't even say 8:45, but by 9 o'clock is the day that I think I'm ready to retire. So there's a good chance I'll be working until I'm 90, because I don't think it's possible, not for me. All right, what's this? Case 12.
So this is like a big, kind of like a dermal-based nodule there. Like when I see stuff like this on the tests. But looking at, I think you can see a little bit of like bones.
Good.
And like deep down. And then it was hard for me to appreciate at first. Like I couldn't even find fluffy, feathery pink material that's good for gout. This is like the mean of gout and osteomyelitis.
Yeah, this is this is an amputation specimen of a digit. So this is the bone and cartilage, but it's being totally destroyed. And at first glance, my first thought would be osteomyelitis here, an amputation, because most of the time when I see an amputation where the bone looks like this, it's because they have osteomyelitis, like in a toe, on an older adult, often with diabetes or vascular disease or something, and they've gotten an infection, and there's neutrophils and a myxoid change and granulation tissue, and it's destroying the whole bone. It's like falling apart. You can not even sometimes you barely see residual bone because it's so destroyed. But in this case, the gout here is very focal. So there's little islands of feathery clouds, pink cotton candy aggregates surrounded by histiocytes and giant cells. I have to say the osteomyelitis appearance is pretty prominent here, but the gout actually is not really abundant in this case. And since we're already running late, let me just show you a better example that I happen to have seen recently. There's skin. It's as low as I can go, sorry. There's gout. Out of control gout, right? The best ever gout, if you will. Extensive pink fluffy clouds. Sometimes gout usually it looks more pink on H&E, but sometimes it can get kind of a bluish appearance. Kind of myxoid or mucin looking. Even though all the crystals here have been washed out during the H&E staining process and during processing and staining. We're always taught that it's from the formalin that this tissue is submitted in, but actually that's, I think, not the case. Usually most of it is during the H&E staining and also sometimes during processing to some degree. But sometimes it can get a bluish look, but what you see is you can really kind of still appreciate like the kind of ghost outline of the crystals. Now, I don't know what actually this is. Is it collagen or some other? I don't actually know what is there. There are a few little purplish crystals in there, but really you can kind of see that feathery needle kind of appearance. But if you polarize this, you're going to see, I did actually polarize this to the day, and there were only a few focal areas where there were residual crystals. And I've got lots of videos on gout, so you can go see those. But this one, we don't need no polarization needed. Like this, nothing else looks like this. The pink fluffy clouds, and it's surrounded by a brisk histiocytic reaction with giant cells. And in this case, there's a little bit of bone. It's purple right there. This is a non-decalcified section. Oh, look. That's the area, actually. When you see in a gout specimen and it looks brown, that brown is not actually brown pigment. It's actually air bubbles. It means that there's retained non-dissolved crystals. And if you polarize it, it will actually show up. Let me gotta turn off the autocorrect. Put that in, turn up the light. Oh, maybe I'll turn it on again. And now off, and then ta-da! There's the birefringent crystals here. So even better if you smear it fresh and air dry it onto a slide. So on this one, the cut surface grossly was chalky, and so the pathologist assistant knew it was going to be gout, and they took some and smeared it on a slide. But you can see it here on this section. If you get lucky on a big case of gout, sometimes there'll still be areas that have retained crystals. So there's a little trick for you that if you look for the brown areas like that, that's the areas where you're going to have retained crystals. But the other trick is that you can cut a section of this tissue. And so we actually did that, cut a section of it, heated up to melt the paraffin off, because paraffin has crazy polarization. If you have never seen that, take an unstained slide sometimes that has paraffin on it and look at it under polarized light. It has crazy like sea of Maltese crosses that like spin when you rotate the polarizing lens. It'll keep you entertained for a long time, if you're like me at least. So anyway, gout sometimes can be real extensive and involve the bone of the digits and cause complete destruction of the bone to the point that amputation is required. And it also, clinically, I've seen times where it was amputated thinking that it was osteomyelitis, but it actually just ended up being gout. Maybe with osteomyelitis, or maybe the inflammation was just from the gout. I don't know. And it also didn't matter because when the whole phalanx is destroyed, I mean, that I would want my digit amputated too if I had destruction of my phalanx with a huge gouty tophus and it was extremely painful. I think that that's probably would be potentially help the situation. So in this case, the bone was like totally destroyed. I think I got another section here. Yeah, here's the bone. Here's more of the gout islands. This one's a little more pale because it was decalcified. And so it makes the H&E stain pale. But you can see the bone is just completely destroyed by gout. So such a terrible disease. It's so morbid, so painful. But it's very classic. So again, we don't really, that is gout. I don't think there's anything else that I can think of that looks like this in pathology. So when you got that, you're good to go. But if you want to see the crystals, because let's face it, crystals are kind of interesting to look at. You can use those tricks I just taught you to go find it. Here, a less dramatic example, but there is also lots of inflammation. So maybe this patient also had infectious osteomyelitis. I'm not sure. I don't know the history here. They very well may have. It would really depend on the clinical and on culture results. But this was also coexistent, at least gout and potentially osteomyelitis in an amputation specimen. Okay, this is 13.
So this one, it looks like there's, like, you can see a lot of mucin, and then also like a myxoid stroma. It also seems like there's a lot of blood vessels, like intermixed with like the myxoid stroma.
Yep.
So this one we think is good for angiomyxoma.
Very good. This is myxoid. It has prominent kind of branching vessels. The cells, it's hypocellular, and the cells usually kind of look kind of like a plump fibroblast. Sometimes they have a bean-shaped nucleus with a little blob of pink cytoplasm, similar to the kinds of cells that you see in deeper, like intramuscular myxomas. So this is cutaneous myxoma, also known as superficial angiomyxoma. So to me, those names are synonymous. I regard them as synonymous, at least. These are unrelated to another entity, which is known as a deep angiomyxoma, or so-called, air quote, aggressive angiomyxoma, which is in a large, deep mass in the vulva that deeply invades the pelvis. Is not really aggressive, but it is a deep and sometimes hard to remove, and so it can have persistence/recurrence. So unrelated, and it looks quite different from this, but people often get concerned if they see anything myxoid in the vulva. They worry about the aggressive angiomyxoma, particularly because the name makes it sound like a really bad thing. It can be problematic for patients. It can be morbid, but it's not malignant. Okay, so anyway, here it's myxoid. It has the vessels. So the other thing it tends to have is cutaneous myxoma, aka superficial angiomyxoma. Often, not always, but often has entrapped adnexal structures with cystic change, either hair follicles and or sweat ducts or sweat glands, and they often get entrapped in the middle of it and has some cystic change. Some people have postulated that these actually may be because maybe these are actually like hair follicle neoplasms that have abundant myxoid stroma, like a myxoid stroma predominant trichodiscoma. I know Tim McCalmont has talked about that idea before, which I have seen cases that did have kind of overlap between a hair follicle tumor and myxoma. So I think that's a really fascinating idea. All right, the other thing is that there's a clue for this is that about like 25% of cases will have scattered neutrophils, which is a kind of unusual finding. So if you see a myxoid thing and there's scattered neutrophils, that's a good clue that you're probably dealing with a cutaneous myxoma, superficial angiomyxoma. I would point out if there's an ulcer with neutrophils on the top, then that rule kind of goes out the window, because of course there'll be neutrophils in the dermis because they're coming up to the ulcer. So, and where might this be on the body? Look at all these things. Where do you think this is anatomically? You got thick, smooth muscle bundles, a bunch of them. You got some apocrine glands. This is the nipple, probably. Could be the vulva or the genitals, but probably not, because usually the smooth muscle bundles are smaller in the genitals. I don't have the history here, but if I were to vote, I would say this is nipple skin. And the reason I bring that up is because cutaneous myxomas can be associated with what disease?
Carney's complex.
Yeah, Carney's complex, Carney's syndrome, okay? Not to be confused with Carney's triad, which is totally unrelated. You should only get one eponym if you describe multiple things. One eponym in your lifetime. That's my rule. And I have the eponym for that to be called Gardner's rule of eponyms, okay? Because Gardner's syndrome's already taken, right? And to my knowledge, I'm not related to the Gardner that described familial adenomatous polyposis with extra GI manifestations. But anyway, so we're coining it here today. Gardner's rule of only one eponym is that you should only get one thing that your name gets applied to, otherwise it's confusing. All right. That's the way I would do it. So the point is that Carney syndrome, right, or Carney complex, which has a variety of different internal things and other tumors it's associated with, you can look that up. But they tend to get multiple cutaneous myxomas, and in particular, myxomas, for some reason, of the nipple, the eyelids, and the ear. So if you see, most of the time when I encounter a myxoma on the skin, it's just solitary, incidental, and unrelated. to Carney's complex. But if a patient has multiple myxomas of the skin, or they have myxomas of those 3 anatomic sites, then I'll usually bring up, hey, you may want to work this patient up for Carney's syndrome and make sure they don't have that, okay? The one other thing is that sometimes it's hard to tell this apart from focal cutaneous mucinosis or focal dermal mucinosis. The things that help me are if I see more prominent branching vessels, if it's larger or goes deeper into the dermis, if there's scattered neutrophils, if there's entrapped adnexal structures. All those things would make me favor a myxoma. If it's just a little pocket of loose mucin, a single little tiny papule on the skin that they thought was a basal cell or a nevus clinically, then I would call it focal dermal mucinosis, focal cutaneous mucinosis, same thing. Every once in a while on a small shave, I'm not sure, and I say dermal mucin. And it could be focal dermal mucinosis, or it could be the top of a cutaneous myxoma. These are benign, but they can recur locally, especially if they're not completely removed. I don't think that you need to do a big excision on them, but just be aware that if you don't get it all out, it can grow back, and if it does grow back, you can then remove it. So, and if you saw something like this with pleomorphic cells, and it was maybe a larger lesion in the extremity of an older patient, you might worry about a myxofibrosarcoma, which can look like this from low power, but has ugly pleomorphic cells scattered in it at high power. All right. So with that, as usual, I got through about half the cases. You guys can go to clinic and then enjoy your Friday and your weekend, and I'll continue on alone. And anyone who wants to stay and it's free is welcome to, and I'll try to get through the rest of these for the sake of our online viewers. But thank you so much, guys. Have a great weekend.
Thank you. Thank you.
Okay, I've sent the derm residents off to clinic now because, as usual, I'm talking too much and running late. But I'll go through the rest of the cases here for any residents who are left, and maybe none are left, in which case I'll just talk. Are any of you guys still there, residents or fellows?
I can take this one.
Oh, hey, we do. We still have some path residents here with us. Excellent. Okay. Go ahead, Ray.
So this one looks like not much going on the sponge biopsy. Looks like maybe a normal skin biopsy.
Normal skin differential. Good.
So for normal skin, you would go like systematically, but like on this one in the papillary dermis, there are some like very sparse deposits of amorphous material that are like lined by these macrophages, melanophages.
Good.
So this is suspicious for amyloid.
Good.
And
what kind of amyloid?
Macular amyloid, because like it can be lichen amyloid, but can be macular amyloid. Does not have the lichen sclerosis or like those kind of changes with it. So, and I think mainly on clinical, both are derived from keratin.
Good.
So based on clinical history and features, I think we can distinguish between lichen amyloid and macular amyloid.
Very good. But I agree with you that lichen amyloid and macular amyloid are both like in the same spectrum of process. The etiology and what we see has a lot of overlap. The real difference is just a clinical kind of terminology. And they both, the important thing is that both of them are, as you said, keratin-derived amyloid, localized to the skin, and not associated with systemic amyloidosis. So totally not related to light chains or systemic amyloid at all. So the differences are, the most important thing is, A, how do we recognize this? First of all, it can be very subtle. So it's one of those things that if you're not thinking about looking for it, at low power, it's easy to miss. It can also be very focal. Like here, look, in this papillary dermis, that's normal papillary dermis. This papillary dermis has this little aggregate right here, and this one right here. And they're, unfortunately, the scan's a little faded and not as crisp as I'd like, but you can see they're kind of homogeneous pink stuff with cracks. And then, as you nicely pointed out, in the cracks, we have melanin-laden histiocytes, or what we call melanophages. So this process happens that the keratinocytes begin to break down. Some of them break down and fall into the dermis, and their keratin and other proteins, it's not purely keratin, but it's keratin and a mixture of other proteins, is my understanding, begin to compact together here into little clusters in the papillary dermis. And in the process, the melanin that is residing in the keratinocyte cytoplasm also falls out. and it gets eaten by histiocytes or macrophages, whatever you like, and those melanophages get trapped in the middle of this. So I find that really helpful. The amyloid itself looks just like other amyloids, but the location of it in the papillary dermis, not around vessels, not in the deep dermis, is how you know it's not amyloidosis of the light chain type. It's not systemic amyloid. The other clue is that it has, almost always I will find, focal pigment, melanin pigment trapped in the little cracks. I find that really helpful for keratin-derived amyloid. And then this really, to me, microscopically has a lot of overlap with the cytoid bodies, you know, that we see in interface dermatitis. When you get cytoid bodies dying keratinocytes, they can pack together and give you a look that really overlaps with this. And it makes sense because it's the same kind of process. And we see that kind of around like some types of tumors, like seborrheic keratosis or basal cell carcinoma and other epithelial tumors where you can get a lot of dying epithelial cells that clump together, and they give you an appearance because it very similar to this keratin-derived amyloid. So macular amyloid clinically is usually going to be hyperpigmented macules or patches on the upper back, the trunk. It's thought to be partially associated with rubbing or chronic irritation. Some authorities have said it's more common in people of Asian ancestry, but I don't know if that is really true or not, or if that it has to do with actual skin type, or if it has to do with different cultural practices. So I'm not totally sure about that, but that has been claimed in some cases. But it tends to be on the upper back, and the macular amyloid form of this keratin-derived amyloid tends to be very subtle. It looks almost like normal skin, and you really have to hunt. Look, I looked at all the papillary dermis, and I only found like 2 little foci of that amyloid, okay? Otherwise, if I wouldn't have had this, all I would have been able to say is that there's melanin pigment incontinence, which could be associated with post-inflammatory hyperpigmentation or post-inflammatory pigmentary alteration, which basically goes hand in hand here with this this macular amyloid. But if I couldn't find those little foci, here's one other focus right here, one little tiny globule of amyloid, all right? Very focal, very subtle. So lichen amyloid is the same type of amyloid, but it tends to be more abundant, tends to have lichen simplex chronicus changes of the epidermis, so epidermal hyperplasia, acanthosis, hypergranulosis, hyperkeratosis, and it's usually multiple nodules that are thickened and very itchy on the lower legs, particularly on the shins. And is probably, I don't know which is the chicken or the egg, but it itches, so people scratch it, and the scratching produces more of that breakdown and keratin drop out into the dermis and more keratin amyloid. So I don't know if it arises because people are scratching at their lower leg, or if they scratch and then the LSC change comes on top of the amyloid. But those two go, you see that, plus usually LSC changes in the epidermis, and it's going to be on the leg. So here we can tell this is a real thick dermis, and it doesn't have any stasis vascular change, so probably it's on the trunk. So on the test, if they asked you, is this macular or lichen amyloid, I would say it's macular amyloid because it's more subtle, it looks like back skin, and it doesn't have the LSC change. So that's kind of the way, but to me, macular amyloid and lichen amyloid, like I said, are really on a spectrum. They are the same spectrum of process. They just present differently clinically. And when I make these diagnoses, I always, my practice is to always add a comment. This is a form of localized cutaneous deposition of keratin-derived amyloid. It is not associated with systemic amyloidosis. And the reason I do that is I once saw a case long ago where a patient had this diagnosis, and they got referred to my hospital to have to see the hematology oncology clinic, the amyloid clinic, to work them up for systemic amyloidosis, because their doctor saw the word amyloid and didn't know about this uncommon dermatologic, esoteric disease, and they thought amyloid needs worked up. Let's send them to the amyloid center. So I made sure to let everyone know, nope, this is a skin disease that sounds like it would be associated with amyloid, but it's totally not related to plasma cells or light chains or bone marrow biopsies. None of that stuff needs to be done here. So it's really important to recognize this clinically and to make sure that our clinical colleagues are aware that this is not, all the dermatologists I work with know clearly that this is not a systemic amyloid associated disease. But I think this person that I was thinking of long ago, I think they were being seen by someone who's a non-dermatologist and wasn't familiar with this esoteric skin disease. Understandably so.
Dr. Gardner,
yes.
Would you send this to mass spec or no?
Nope. In this case, I wouldn't. You could do it if you wanted to, although I think it's so focal here they may not be able to. But to me, in my opinion, this is not compatible with AL type amyloid. I have never seen nodular amyloidosis or systemic amyloidosis that are AL light chain that deposit like this. I've never seen them make little papillary dermal deposits with melanophages present in the cracks and no involvement of the vessels or the deeper dermis. I've never seen AL amyloid present that way. If someone online has seen otherwise, please let me know. It's possible, but I've never seen that. And so to me, this pattern of deposition of amyloid is, to me, totally diagnostic of keratin amyloid and not light chain amyloid. But if you do Congo red, my understanding is that it will light this up, but I've always had trouble getting Congo red to work well in my laboratories, so I feel like a Congo is a finicky stain. On thioflavin T, it will stain beautifully bright green under fluorescent light examination, just like light chain amyloid would. But again, the localization and the presence of pigment in there tells me that this is going to be keratin derived. So yeah, I personally don't send this for mass spec. But you could definitely, if you had any doubt, you could send it for mass spec. That would be a fine way to make sure that there was not light chain. What was the other thing I was going to say? Oh, you can also do a keratin stain. So in the past, I was a bit of a doubter about this. I had tried it, and I had not found that keratin stained this amyloid. But more recently, a colleague of mine informed me that keratin 903, we had done a paper they presented for our dermpath journal club, and found that of the keratin stains, keratin 903 particularly highlights this keratin-derived amyloid, whether in macular amyloid, lichen amyloid, or amyloid associated with basal cells or SEBs or other things like that, and it will stain it really nicely. So, and it does seem to work really well. So if you would like to try to get this stuff to light up, doing a cytokeratin 903 immunostain will stain it. I would point out, though, that because not all of this material is keratin, it is other proteins, not all of it will stain with keratin stain. You will get like focal staining scattered in here, but it won't stain the entire nodules of the entire focus of amyloid, and not in my experience. But you will get some amyloid or some keratin staining in here if you do a keratin 903 in most cases. So I feel like I don't really need that, because once you detect it here, it's really easy once you know the H&E clues. But that's a great question, Raheel. So there, we've covered that at length. But this is one where you got to be kind of clinically suspecting macular amyloid and looking really closely across all of the papillary dermis, and maybe even doing some deeper sections to look to see this stuff, because it can be quite subtle. This case is case 15.
So this is another epidermal differential, even in low power.
Yeah, very
of
busy.
Cells in the dermis.
Yes.
Really busy. So I think in higher power, we can see these cells spindle shape, more like fibroblasts, and then some washout space, maybe mucin. So
good.
It could be Scleromyxedema or NSF, as we discussed in the previous slide.
Good. Yeah, it's hard to tell. It's a faded slide here. So there's space, like you said, between all, definitely way too many fibroblasts. And to me, this, you know, you could get this and you might think this looks like a punch biopsy of a spindle cell neoplasm, right? I mean, I'm a soft tissue pathologist, and if you just showed me this and didn't give me any history, my first thought as I see a dermis filled with spindle cells, I'm going to think, I wonder what kind of spindle cell neoplasm this might be. So I feel like I don't feel like it's always taught that way, but I think both Scleromyxedema and NSF, if you just look at the slide with no clinical information and you're not in the middle of a metabolic disease lecture like we are now, they often make my mind think of a spindle cell tumor. So I don't know, maybe it's just me, but I think that's a useful thing to keep in mind. If maybe your brain works like mine, if you're out there, if you get these confused with spindle cell neoplasm at first glance, you're not alone. So I think we have a mucin slide, perhaps. Maybe not. Let's see. Nope. But if you stained this with a colloidal iron or Alcian blue, it would all this stuff in between would light up as looking bluish and having mucin here. And so this case, per the answer sheet, is a case of NSF, nephrogenic systemic fibrosis, or what's the other name for it? Is fibrosing systemic dermopathy. Hold on. I can't even keep these things. I'm going to leave this in. So if you're out there and you have to Google sometimes to remember the alternate name of esoteric entities, well, I do it too. So, because, you know, I want to make sure I don't get the thing wrong. So, nephrogenic systemic fibrosis, or the other name was nephrogenic fibrosing dermopathy. I think NSF is the current name that's used. So this is the one we were talking about this earlier in the section on Scleromyxedema, that the appearance here can look, to my eye, essentially identical to Scleromyxedema. The difference is clinical history, knowing that the patient has renal failure and was administered a gadolinium contrast agent and has other systemic symptoms that would come along with this. They're often, I believe, have a joint involvement and can have some synovial involvement and joint flexibility issues and other things. So I don't think I've ever diagnosed a case of this in real life, because now that this entity is recognized, it's become vanishingly rare, because when people have renal function that is not good enough to receive gadolinium, they're not given the contrast agent. And again, I don't know the exact specifics of when you can and can't give contrast, MRI gadolinium contrast to patients. So I'll have to let my radiology and nephrology colleagues out there chime in on that. So, and Li Ping, like you said, I wasn't aware of how you can tell these apart without the history, but I know that you mentioned that this tends to sometimes go deeper in the dermis than Scleromyxedema, and this case would seem to support that. This goes way down, all the way down. It looks like where subcutis should be, it's replaced by these plump fibroblastic cells and intervening collagen and mucin or myxoid change. So a good dramatic example, a little bit faded, but an example of something that's very rare nowadays. Okay. Next case here, we have case 16. Anyone want to take this?
So in this one, there is like wave biopsy, which has bluish mucin deposition.
Right.
But like there are no associated like blood vessels or something that will make it like a myxoma. So it is just like focal mucinosis.
Yeah, exactly. And I don't know why this happens, but it's just this kind of, it seems to be an incidental little aggregation of mucin, myxoid substance, hyaluronic acid, that forms a little papule. And I feel like the times I've seen this, clinically, the dermatologist will often be wondering if it's a nevus or a basal cell. It's like a little skin-colored small papule, okay? So, and that's why it's been shaved off, because they were thinking it was, either a basal or a nevus maybe, or a small, like a non-pigmented seborrheic keratosis, something like that. And then all we see is hypocellular mucin replacing and kind of filling in the dermis, okay? So yes, without the vessels or the scattered neutrophils or the entrapped nexal structures, and it's a small papule, I would call this focal cutaneous mucinosis, focal dermal mucinosis, same thing to me. If I wasn't sure, especially if it was a really tiny shave, like say I just had like this, how would I know? Or if I didn't have any clinical info, this could maybe be the top of pretibial myxedema. If this was from the lower leg and no one had told me any clinical and just said biopsy, well, I would try to get clinical information, but I would say dermal mucin deposition. If it's a solitary papule, it would be, focal cutaneous mucinosis. If this is a larger nodular, multinodular, or plaque-like process on the lower legs, then this could be thyroid dermopathy, pretibial myxedema, and recommend workup for hyperthyroidism or correlation with patient history. So I'm lucky that I work in a job where I have clinical photos most of the time and great clinical history, but I know that many, if not most of my dermpath colleagues out there don't have that luxury and really often have limited information available. And it really, really makes our job harder. So if you're watching this and you're a treating physician, please make sure to give clinical photos and good clinical history, because it can really help us make the right diagnosis. All right, so sometimes that's what I'll say though. If I don't know, I'll just say there's a myxoid change of the dermis and give that differential and then let them work it out. Or I'll say maybe it could be the top of a cutaneous myxoma. I just can't tell, right? The other thing is, from low power, this kind of looks a little like solar elastosis, right? Mucin and solar elastosis both look blue, but when you go closer, mucin is like kind of speckly and kind of grainy looking. It's hard to tell here on this scan, but if you have a light microscope and can flip the condenser, you can see there's kind of a granular looking speckled kind of texture to it. And it sometimes is much more, when it's abundant like this, it's easy to see, but when it's subtle, it can be really hard, like when it's just little bits of it. And then solar elastosis will actually be like big fibers. You can see there are some elastic fibers here in the background. They're kind of showing up clear in this case, but the mucin itself is like very like kind of loose and speckly stippled appearing. But I think those two things from low power can be hard to tell apart. And so with practice, you can do it. Otherwise, you can use stains to help you. You could use an elastic stain for elastosis. You could use an alstrom blue or colloidal iron for highlighting the myxoid mucin material. But generally, H&E is good enough. All right. This case,
so for this
17.
one, low power, we can see a cyst structure.
Good.
But seems not true epithelial lining of the cyst wall. So I always confuse, is it a synovial cyst or ganglion cyst? Kind of like this.
The reason you confuse it is because, to me, those are like, they are on a spectrum with one another. They are cystic outpouchings of the synovial space that get filled with synovial fluid and may have a partial or complete synovial lining, or may have no lining at all. It just depends on the case. So to me, the ganglion cyst, synovial cyst, Baker cyst, which is like a large ganglion cyst from behind the knee. I think there's another name on the finger, retinacular cyst. And there are a few other orthopedic related names. They all are, to me, the same spectrum of process. They are a dense fibrotic cyst wall, and then blue mucin myxoid material, which is actually just synovial fluid, but it looks just like mucin, and plus minus a lining of synovium. You don't have to have a synovial lining. I would say most ganglion cysts I see have very little, if any, synovium there, like actual synoviocytes. They just have this dense, compressed kind of sclerotic collagen. And even though there's no lining, I don't know how to explain it, but you can tell that, to me, it looks so like perfectly flat that even without the mucin there, say we took the mucin away and you just had this piece, I would argue this is the edge of a pseudocyst. And I don't know how to exactly explain that, but hopefully that makes sense to you, that it looks like too perfectly flattened along the edge to just have been torn away during surgery or to be an artifactual space. Like something was there in the patient's body that compressed this collagen and made this kind of pseudocystic fibrotic lining. So the reason I bring that up is when it's a perfect cyst like this, no problem, right? But a lot of times we don't get it, all the contents wash out, we get a fragment or just the edge of this, so that being able to see dense fibrosis and a sharp lined edge to it with no lining cells is useful, because it tells me we're either at the edge of a cystic thing like a synovial or ganglion cyst, or maybe we're at the edge of a pseudocystic capsule around a foreign body and the foreign body has fallen out, or they plucked it out intraoperatively and we weren't told that and we just got the lining around it. Or it's a capsule around a breast implant. Usually that gets a lot of synovial metaplasia. So I think this is a very boring kind of specimen, right? But that ability to tell that this is the edge of a pseudocyst, I think is a really helpful and kind of hard to explain practice. So I don't know if I'm helping you at all, but I hope that makes sense a little bit. So when you're lucky, though, you'll get the whole thing here, and you'll get the myxoid stuff inside it. You may get some scattered little histiocytes that are kind of like muciphages that are eating up some of the synovial fluid in there. You sometimes get fibrin, sometimes a bunch of fibrin deposition and hemosiderin and blood and hemorrhage. When you get like trauma, people sometimes try to crush their ganglion cyst with a large book. Like in the past, people have referred to these as Bible cysts because, sometimes people would have large like family Bibles in the days before there were online ones, and they would then use that biggest book in the house to try to crush the ganglion cyst. If you're a patient watching this, I am not advocating for that, although it will sometimes make the cyst rupture and go away. The cyst may refill, and it also may cause other trauma to local tissue. So most authorities don't recommend that, although I have heard that it can actually work. But in any case, just so you know, that sometimes you'll hear people talk about that colloquially. But you can also have other reasons for hemorrhage and trauma in these. And when you get a lot of hemorrhage and trauma, a ganglion cyst will look quite different. And it will get a lot of reactive change, granulation tissue and reactive change around it, sometimes mixed inflammation, a bunch of fibrin, and it can begin to look like a chronic bursitis. So to me also, a bursa sac will look I can look identical to a ganglion cyst. It really just depends on the clinical and intraoperative findings. And so if I'm not sure, I'll say there's dense fibrosis or dense fibrous tissue and focal synovium. And this could be a ganglion cyst or it could be a portion of bursa. It just depends on the intraoperative findings. And so there you go. But just so you know that there can be a lot of reactive change in ganglion cysts and in bursa sometimes, okay? The other thing I wanted to point out is that sometimes the mucin, like I said, the synovial fluid can wash out during processing and be completely empty and clear, okay? And the other thing is that sometimes it tends to leak out of the cyst and kind of infiltrate the adjacent tissue. And what that does is give you little pockets of loose kind of edematous or myxoid area, often with little foamy, bubbly, muciphage type histiocytes. Sometimes that can be so abundant that it kind of resembles the changes you see in a myxoma. So sometimes if I just see fibrous tissue with myxoma looking change, with no cystic area, no pseudocyst, no synovium, I'll still say these changes could represent changes adjacent to a joint or a bursa or bursitis, or they could be changes adjacent to a ganglion cyst. And you can see this same spectrum of changes we've talked about here. You can see those in digital mucus cyst or digital myxoid cyst, which I think of as kind of a cutaneous manifestation that is very similar to ganglion cyst, but it is on the skin right near the proximal nail fold, right just below the at the start of the base of the nail, the fingernail or the toenail. So the reason I belabor all this is because all of these things can be applied across bursas, synovial and ganglion cyst, digital mucus cyst, can all have these same spectrum of changes, okay? So I think we've made a boring thing as exciting as I possibly can. I did not really point out the synovium itself. I guess I can do that. We don't really have very good synovial cells, actually. Right here, this is kind of synovium. They look kind of like histiocytes that are layered on the edge of this space. Sometimes they're a single layer, sometimes they're several layers thick. They look almost like an epithelium, except they're like not tight enough. They're not perfect enough, right? An epithelium should be like continuous, and should be like nice and tightly connected together because epithelial cells have tight junctions. That's their job, right? To make a waterproof barrier. And synovial cells look kind of, I always kind of jokingly say, they look like if histiocytes got together and made a half-hearted attempt to try to make an epithelial lining. That's what synovium looks like to me. Because I don't really know, it looks kind of like epithelium, but less continuous, less perfect, more feathery and loose and falling apart. So I don't know if that works for you, but I've struggled to explain what synovium looks like and how to recognize it, because it can be like really subtle and thin, or it can be really thick, like in reactive, joint situations like in arthritis. So it just depends. So I don't know if that works for you, but that's kind of how I describe synovium. So there we go, like 15 minutes about ganglion cyst. If you're still watching, you get an A+ from me. All right, next case 18.
Okay, Dr. Gardner, this would be my last case. I have to leave after that.
No problem. I'm sorry for keeping you guys so late.
No problem. So this is, or at low power we see bubbly or mucoid-like of nodule in the middle of this biopsy. Does not have the bluish tinge of mucus at this power, but we can stain it to prove it. But like it is in the background of like a scar, and with this bubbly background, with this bubbly appearance, and maybe there is some like or part reported there are some like histiocytes. So this would be good for triamcinolone injection.
Excellent, very good, yeah. So this is once you've seen it a few times, it's pretty characteristic. It kind of has a pale blue, pink to gray to blue, depends on the H&E appearance, and it's very bubbly because this is injected steroids, Canalog or triamcinolone injection, and this is it's bubbly because corticosteroids are lipid based, right? And so some of it washes out, but some of the material stays here. And usually you're going to see this because they've injected a scar or a keloid, and then it later gets surgically removed. And it can persist as a little pockets here in the middle of the dermis for quite some time after the injection. It seems like I've seen cases where the injection was many months previously, and they still had some of it there. And occasionally, you can see histiocytes and even giant cell reaction around this, which is kind of interesting that, it's a steroid that's supposed to inhibit inflammatory response, but it still doesn't seem to deter always the histiocytes and giant cells. So the background is a very dense scar. This is old, mature scar. I don't know how old, but it's like so dense and pink. And it doesn't look like parallel fibroblasts here because we're cutting them in cross-section. They're actually coming out of the screen at us. That's why they look round. If we would be cutting them 90 degrees to this, they would look like parallel fibroblasts running parallel to the epidermis and fascicles. So yeah, this was a dense, old, mature scar, maybe a hypertrophic scar, and it had a triamcinolone injection. So we just usually see this incidentally, but it's just important that when you see this, you recognize that's just injected steroid, and it is not anything else. All right, good job. All right, so going forward, I'll just finish up the rest of the cases here and describe them, and record the video. Anyone else, you guys are welcome to leave and go about your day. All right, so this is case 20 here. Oh, actually, no, it's not. Case 19. We are on acral skin or near acral skin. It's got thick acanthotic epidermis, hypergranulosis, thick orthokeratin, and this pink band, which is called the stratum lucidum, even though it looks pink or orange rather than actually clear or pale. That's the way it usually looks on H&E. And the only place in the body that you can really see a well-developed stratum lucidum is acral skin, palm or sole skin, or skin that has been rubbed or scratched and has chronic reactive change, or lichen simplex chronicus, prurigo nodularis change. And the reason here, there may be a little bit of both. This is skin that is acral or near acral because this is from the proximal nail fold, which is the area, non-medical people will refer to as the cuticle, the area that they, push back when they do a manicure. The skin just below that is actually called the proximal nail fold, and which is between your your distal interphalangeal joint and the area where your nail starts. And in that area, if you get a translucent, bluish, pale papule, sometimes with ulceration or reactive change, like this is starting to kind of ooze out and break through the skin. So sometimes they ulcerate or patients can pick at them. But underneath, what you see is we have this pools of blue mucin. And in this case, this is just like what we saw in the ganglion cyst. And some people say that, so this lesion here is called a digital mucus cyst or digital myxoid cyst. And I think of this basically as the same kind of thing as a ganglion cyst, but it's small and it's in the proximal nail fold. Some people have said, well, this should technically not connect with the underlying joint, whereas a true ganglion cyst will connect, but I don't really understand if this is not coming as fluid leaking up from the joint. How's this myxoid material getting here? So I don't know who makes these rules, but in my opinion, I think these can overlap. And I've seen some hand surgeons will call things that are obviously deep ganglion cysts, they'll still call them digital myxoid cyst or digital mucus cyst, even though it's not in the proximal nail fold and is down, in the digit connected to the joint. So some hand surgeons will actually use digital mucus cyst and ganglion cyst synonymously. I think of them as presenting a little differently, but the same spectrum, that you've got this pseudocyst. In this case, I feel like these ones in the skin almost never have any synovial lining. They just have a dense kind of layer that's kind of a sharp cutoff. And then myxoid change, a myxoid mucin material filling the cyst space, sometimes breaking through the epidermis, with variable amounts of ulcer, inflammation, reactive change. I've sometimes seen these, just not long ago, I saw one that was clinically thought to be a traumatized verruca, because I assume the patient had been picking at it, understandably. And on the original section, I saw some epidermal changes that looked verrucoid and some neutrophils, and then I did deeper levels, and I saw some little aggregates of mucin, and I was like, this actually probably represents the surface of a traumatized digital mucus cyst that has some secondary lichen simplex chronic exchange from picking. So that's a nice example to know when you're lucky, all the mucin will stay there, but a lot of times the mucin washes out, and so what you'll get is just an empty space. But this empty space like this at this site is still good for a digital mucus cyst. And the other thing is that sometimes what you'll get also is that the myxoid material seeps out into the dermis, and you'll get adjacent areas that look a lot like focal cutaneous mucinosis, focal dermal mucinosis, or almost like a cutaneous myxoma. Sometimes it will begin to get those bubbly muciphage cells like we saw in that last ganglion cyst, and you can see areas that become a little bit more cellular, or it'll be very loose. It can be any spectrum of those. So if I see a papule from the proximal nail fold that just shows mucin in between dermal collagen with no cystic space, I'll still say that's consistent with a digital mucus cyst, because sometimes that's all you see and you don't actually see the cyst. You just see a pocket of myxoid material that looks like digital, like dermal mucinosis or a myxoma, but it's a small lesion right there on the proximal nail fold. That's still, to me, compatible with the digital mucus cyst, even if you don't see the actual pseudocyst itself. So it's a good one to know about, and a very nice example. I would say most of the time we don't get lucky enough to have a perfectly intact one with all the mucin retained. This is like textbook, too good to be true. Most of the time it's not this good. Okay, this is case 20. And here we have skin, and we have multiple nodules of really dark, it looks almost black here on this scan, but on a good scan or on an H&E, this would look like dark purple. And this is dark purple. This is calcium, and calcification that has not been decalcified will look dark purple. If you use decalcification, the purple begins to get taken away. The purple is actually the calcium itself, and so it'll look different if you decal it. The calcium here is not actually bone. It's actually loose aggregates of calcium. How we know is a bone is usually going to be more well formed, but calcifications are often fractured and fragmented like this, and sometimes also they have on this like loose, granular, powdery kind of appearance, but some of it very fine, some of it bigger and more chunky. So this is, depending on the situation, this is calcinosis cutis, or in this case, this was multiple nodules on the scrotum, so you can call this scrotal calcinosis, but both calcinosis cutis and scrotal calcinosis, to my eye, they look the same microscopically. The difference is the clinical presentation. So they are calcium that's either big chunks with fragmentation or powdery granules with big blobs and chunks, making one or multiple aggregates in the dermis, usually surrounded by histiocytes and multinucleated giant cells. So they're getting kind of a granulomatous giant cell, foreign body giant cell reaction around the outside of the calcification. All right, that's very typical of this. And they may have inflammation, may have fibrosis or scar, but usually not too much. And in this case, again, the clinical information was that these were nodules on the scrotum. The other clue, if you're in a test and you've not been given the clinical information, is look at the skin in the background to try to figure out where you are. And in this case, there's multiple small bundles of smooth muscle, many bundles of smooth muscle, and they're kind of small and they go down into the deep dermis. That's the common finding in the scrotum or the labia majora. In genital skin in general, we'll have increased density, increased number of smooth muscle bundles, and they tend to be smaller than the smooth muscle bundles of the nipple. So the nipple and areola also has increased smooth muscle, but the bundles are usually really big and large. So that's a kind of subjective, but with practice you can tell like these are much smaller than the bundles of smooth muscle that I usually see in the nipple. So if I see this, I'm going to say this is probably from the scrotum or the labia majora or somewhere else around that site in the genital skin. So based on that, plus the calcium, I would say the answer is scrotal calcinosis on a test, even if I wasn't given the history. So it's been debated why this happens in the scrotum. It seems to be idiopathic and not associated with any systemic abnormality, as some cases of calcinosis cutis elsewhere are sometimes associated with, scleroderma or systemic sclerosis, or with Crest syndrome, or other types of other types of systemic abnormalities. And so, that's what the word I'm looking for. Phosphate or calcium abnormalities, sometimes parathyroid abnormalities, and dermatomyositis and other things. You can go look up the whole list. But these in the scrotum don't seem to be associated with that, to my knowledge. They're just idiopathic. Some people have postulated that maybe these are because of epidermoid cysts or epidermal inclusion cysts that rupture and then get calcified. And I think there are some people that still propose that that's the mechanism. I've had a hard time believing that, because when I've seen this in practice, I usually don't see any keratin or any cyst lining in the cases that I've encountered. So maybe that's what happens, but I find it kind of strange. Why would that at the scrotum happen that way and not have any keratin or cyst lining left behind? Whereas when I see ruptured epidermoid cysts elsewhere in the body, yes, sometimes they get a little bit of calcification, but not like this. So I don't know, maybe I'm wrong, but I'm a bit of a doubter about that theory, but some people propose that. But that said, I don't know why this happens, but that's idiopathic scrotal calcinosis, which I think of as kind of a morphologically looks identical to calcinosis cutis from other body sites, but no systemic associations. Case 21. This looks like basically normal skin from the trunk, from the back. And probably, in this case, because it's such a large piece, this was probably an incidental skin in an excision specimen, like for a melanoma or something like that. I don't know the history here, but otherwise you would not be getting someone giving this huge piece of skin as just a biopsy for this condition. So to me, from low power, this looks like basically normal for this anatomic site, for the trunk. Okay, but when we go closer in the deep reticular dermis, the collagen bundles, you could argue they're kind of thickened, but I mean, honestly, they look quite similar to the normal dermal collagen to me. But yes, they maybe are a little bit thickened or swollen if you have a really good eye, I guess. But I feel like it's a really subtle finding at best. But what there is here is that the collagen bundles are kind of separated from each other and have white space in between. And I mentioned earlier that oftentimes this happens as an artifact, that the collagen separates and there's white space artifactually during tissue processing. But sometimes it means that there's a deposit of something here, fluid like edema or mucin. And so it's subtle, but if you look closer, in some of these spaces, there is some wispy blue material. Very difficult to see here because it's A, subtle, and B, it fades out really quickly, as I've mentioned multiple times in this video. So I think in this case we actually have the benefit of an additional special stain to help us see the mucin. So this is a colloidal iron that worked beautifully, and you can see those areas where the spaces were really light up with this beautiful blue color, because there's actually a lot of mucin in here. So it looked washed out on the H&E. So I often kind of am a bit of a doubter, or a bit of a naysayer, I guess, about colloidal iron. I think I'm coming off kind of negatively in this video because I've been telling you how many things I don't believe or doubt about classic teachings in dermpath. So I don't know. But in any case, I often feel like usually with practice you can tell if there's mucin or myxoid change on H&E, and if you can't, a colloidal iron is going to often turn, it always makes stuff look kind of blue. But I will say that there are times where it works really nicely, and this is one of those times. It beautifully highlights the mucin in this case. So if you like colloidal iron, don't let yourself feel like I'm being judgy of you. You're welcome to use it. It's totally fine. I don't often use it, but sometimes for teaching purposes I'll get one like we did in this case, okay? So here there's abundant mucin between the dermal collagen, but like on H&E, the dermal collagen basically looked almost normal, maybe a bit thickened. It's not like been wiped out and replaced and really spread out like by a sea of mucin like we saw in pretibial myxedema. It's really kind of subtle mucin depositing between relatively normally arranged collagen bundles, and there's no increase in fibroblast density, no busy dermis appearance on H&E. Like I said, it looked like normal back skin because this was from the back. Okay, so this is scleroedema. And the name I don't really love because it sounds like it should be edema, but it's actually myxoid deposition. It also sounds very similar to Scleromyxedema, but it looks nothing like Scleromyxedema. So these are like dermpath name-alikes. Scleroedema, Scleromyxedema, and pretibial myxedema. They all sound similar, but they look very different microscopically and have very different clinical presentations. I don't see this very often biopsied, although it's not really terribly rare clinically. It's just recognized clinically and not biopsied. This is a thickened, ill-defined plaque-like area in the upper back, posterior neck region usually, that's firm and kind of indurated to the touch. I think usually normal skin colored or maybe a little bit erythematous. But there's kind of two forms. It can be seen in adults. Often, I think there's an association with diabetes. So kind of an incidental finding in the upper back, this kind of firm, thickened area. And the classic kind of teaching is if you try to kind of pinch the skin gently with your fingers, it feels firm and you can't you can't pinch and pull the skin up because it's too firm to grasp it between your fingers. And so that's scleroedema. So again, in adults, I think an association with diabetes. And then there's another form that can present, I think, more common in kids, and it's often kind of secondary to an upper respiratory infection. Like they had, I think, like strep or maybe viral. I can't remember if viral is associated or not, but I think the classic teaching, like they had strep throat or something a few weeks ago, and now are getting kind of this firm indurated area in the upper back. So I feel like when I've encountered this in practice, it's usually been an incidental finding on an excision specimen just like this. Every once in a while, it'll be a punch biopsy where they're questioning if it's scleroedema. But a lot of times I've asked some of my derm colleagues, and they're like, oh yeah, we see scleroedema, we just don't biopsy it because we recognize what it is clinically. So in pathology, we sometimes get a bias, a sampling bias based on what I think is common or rare is based on what I see biopsied and what I see sent to me in consultation sometimes. And so if something is common but not biopsied, I'll never see it. So I sometimes get a skewed view of how common or rare things are based on what I see in my practice. But that's a beautiful colloidal iron, isn't it? That's really nice. So it's great when it works like that. But let's look up here just for a second. Please note, not only does the epidermis stain blue, but the papillary dermis, there's a lot of normal blue. This is basically, once it comes into focus, kind of the normal amount of blue staining you see in the superficial dermis and around vessels on a colloidal iron stain. So even in normal skin, there is a baseline amount of blue that's going to be present on a colloidal iron stain. So you have to really get used to what normal skin looks like on colloidal iron, or Alshem blue if you like that. I think most people I know that like to use mucin stains use colloidal iron. And then also you got to get, it depends also on the technique used in the lab. These are kind of older histochemical stains, and sometimes they can be finicky and difficult to get to work quite right. They can overstain or understain, just depending on the reagents used and the operating protocol that the histotechnologists are using. So it's one of those stains you got to, optimize its use in your lab and get used to what it looks like on normal skin before you use it much for interpretation. I would just caution you, because otherwise I will find this level of blue in skin, many patients' skin all day long, and it doesn't mean anything. So just that's a caveat that I would mention. So that's kind of why I don't often use mucin stain, because it often will show me, yeah, it's going to be blue if I do it. But here, it worked beautifully. Okay. Scleroedema. Next case. This is case 22, and it's a nice, easy example of seborrheic keratosis. Acanthotic, bland keratinocytes, beautiful horn pseudocysts, or some people call them pseudohorn cysts, and with nice swirly, loose keratin in them, a flat bottom or kind of string sign under the base, all the stuff. I've got other posts and videos about seborrheic keratosis. So why is this seborrheic keratosis included here? Oh, you can see how it kind of overhangs the edge and kind of is stuck onto the skin. All the seborrheic keratosis stuff. Very nice. Well, there's a reason. Let me find it. Because in addition to the seborrheic keratosis, there is homogenized pink material with cracks in it in the dermis directly beneath. Right here, and right here. And so I know that it's kind of hard to see on this scan, but it's homogeneous pale pink, crack artifact between it. This is amyloid. But this is very similar, a little bit bigger, but foci, but very similar to the amyloid we saw in the case of macular amyloidosis, macular amyloid earlier in the case. This is because this is the same kind of amyloid. It's keratin-derived amyloid. It's got pink aggregates, cracks, and in the cracks it's hard to see because this scan's not really in focus, but there are little, this is a melanophage, and here's another one. There are little bits of melanin pigment that have dropped out of the basal keratinocytes along with the keratin and other proteins and aggregated together here in the superficial dermis directly adjacent to the seb, and it's produced keratin amyloid. So it's a relatively common incidental finding. I see this present next to seborrheic keratoses, basal cell carcinomas, and other epithelial neoplasms, both benign and malignant. I see this, I don't know, probably weekly, multiple times a week, I would say. When I see this, the reason that I'm bringing this up in this video is so that you recognize if you encounter this, this does not mean anything clinically. This is a benign incidental finding that is not associated with amyloidosis, systemic amyloidosis. It is not associated with myeloma. It is not associated with AL or light chain type amyloid. This is keratin-derived amyloid. It has all the features of amyloid that we discussed at length that you see in other keratin-derived amyloid situations like macular amyloid of the upper back, lichen amyloidosis of the lower leg, and you can see that same keratin-derived amyloid with the melanin. That is such a useful clue. The melanin pigment present in the cracks, and the fact that the amyloid is right adjacent to the tumor here, right adjacent to the seborrheic keratosis. In a basal cell, it's going to be directly adjacent to the basal cell carcinoma. Here, it's near this papillary dermal vessel, but it's not actually in the wall of the vessel. It's in the dermis. This vessel is just trapped in the middle of it. If you go down deeper in the dermis and look elsewhere in the dermis, around other vessels in the dermis, around deeper adnexal structures, you're not going to see any of that amyloid deposition, okay? If you saw that, that's when I would send it for mass spec to check, hey, could this be light chain that incidentally is depositing next to a seb or next to a basal cell? If you see amyloid here around these deeper dermal vessels or around eccrine coils, then you would think, oh, maybe this actually is a patient with systemic amyloidosis that just happened to be an incidental finding under a seb. I have seen that in a patient with a basal cell excision. They had deep dermal perivascular amyloid deposits. That is not keratin amyloid. That actually is the way light chain amyloid. And so I was all excited that I had incidentally discovered this patient's systemic amyloidosis, and then I looked up their history. They were being seen and were a known patient in the systemic amyloidosis and myeloma clinic. They already had known systemic amyloidosis, and they were just seeing dermatology to get their basal cell carcinoma removed. So it was already a known finding in that patient's case. So that was totally different because the amyloid was deposited deep around the vessels, not next to the basal cell carcinoma. Here, all the deposits, look, here, 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 everywhere. The papillary dermis next to the tumor is filled with keratin amyloid. So this is a seborrheic keratosis with incidental keratin amyloid. When I encounter this, I personally do not mention this in my pathology report to minimize the chance that anyone might read that and get freaked out and think that the patient needs a bone marrow biopsy or an SPEP and UPEP or something else to rule out myeloma or systemic amyloid. I don't even go there because it doesn't mean anything. It's an incidental finding. The reason I teach about it is so that you as a pathologist recognize when you see this, yes, it's amyloid, but no, it is not light chain. It's keratin-derived material, and it's just an incidental finding that sometimes we see with seborrheic keratoses and basal cells and other tumors. Oh, and look, here we're going to actually get a stain. That's really nice. And, earlier I mentioned in the macular amyloid section, that there's different stains you can do for amyloid. So this stain is a stain that I have not used very often, but this is a stain for amyloid protein, for amyloid P, and I believe that it's actually an immunostain. I have actually tried it out a little bit and found it to be a little difficult to interpret. I can't remember if this was the immuno or I think this is the immunostain. But there is an amyloid P antibody, an immunostain for amyloid. There's Congo red. Some people use crystal violet. I have no experience with that. My favorite is thioflavin T, which will beautifully stain amyloid, both light chain amyloid, keratin-derived amyloid, other amyloids, bright green, but you have to have a fluorescent microscope to view it. So if you don't have a fluorescent scope, you're not going to be able to use thioflavin T, but I find it to be a really good stain. But here, this amyloid P looks really nice in this case, so maybe I should give it a try again. I've tried using it in a different setting, not for keratin amyloid, but it stains this beautifully. And as I mentioned, that some keratin immunostains will stain some of, not all of the material, but it will stain focally within this material in keratin-derived amyloid, particularly cytokeratin 903 tends to work really well for that. So you can try that out. I've tried cytokeratin 5,6, which is another high molecular weight keratin, just like 903 is, and it didn't work as well. It did focally, but it wasn't as good. And I've tried pan-cytokeratins like AE1, AE3, and I found them to not work well at all, in my hands at least, for keratin-derived amyloid. So if you want to try a keratin stain, try 903. If you have amyloid P in your lab, give it a go. But again, with H&E, all the things I explained to you, I feel like this stain was done, for teaching purposes here. This was not needed for diagnosis. This was just done for the study set. So beautiful example. Maybe I'll give amyloid P another go. Maybe I judged it too quickly. This is case 23. We have a nodule in the dermis here, and it's cellular. And there's some weird purple stuff in the middle. So before we look at the dermis, I think this is the important thing, is normal dermis and normal epidermis here. The rete get a little long here, and then suddenly the epidermis looks very different, and then it goes back kind of to normal. So the rete ridges are kind of effaced and lost here, flattened out or absent. So the first thing I would think at low power, if I only had this slide, is I would think of a dermatofibroma, because it looks like a nodule of spindle cells. It looks like there's collagen trapping at the edge. There's epidermal hyperplasia and flattening of the rete over top. Okay, the other thought would be that there could be a scar here from a biopsy site. And that's actually both true in this case. So here we do have a dermatofibroma, looking closer, because there's thick collagen, there's plump spindle cells, haphazardly arranged. And as I mentioned, there's many, many different patterns of dermatofibroma. I have lots of videos and posts about that on YouTube and Kiko. You can check them out. There's collagen trapping at the periphery, and the epidermis gets thickened over top and tends to have flattening of the rete. And sometimes when you pick and rub or irritate a dermatofibroma, you will get kind of effaced epidermis and flattened, even thinned atrophic epidermis. People often teach that there's a Grenz zone, a zone of normal dermis between a dermatofibroma and the overlying epidermis. But in my experience, if you pick and scratch at a dermatofibroma and get reactive changes, that Grenz goes away and the dermatofibroma pushes right up against the epidermis and the epidermis begins to thin out. So this is a dermatofibroma, but it's been previously punch biopsied, and I think because it was a large dermatofibroma, probably irritating to the patient, they went ahead and just did a small excision to remove the whole thing. But it had been biopsied with a punch, okay? And so here you can see this hole coming down through that has serum crust and inflammation in it, fibrin, and underneath there is this purple weird material that is like jagged, irregular triangle shapes arranged in kind of chains. If you've never seen this, you will have no clue what it is. If you've seen it once, you will recognize it forever. This is gel foam. And so a lot of dermatologists like to use, if you do a punch biopsy with like a 4mm punch, some people will just put a little plug of gel foam in there instead of doing a suture. And I'm not a dermatologist and don't do biopsies. I haven't done them since training in fellowship, but my understanding from my derm colleagues is that actually has a really great effect and works just as well and has the same cosmetic result as putting a suture in it in many examples. So I'll let you consider that and talk to your dermatology colleagues to see what they think about it. But that's what I've heard from people, is that putting gel foam into a punch biopsy can be an effective way to stop the bleeding and allow it to heal up nicely. So in this case, they just removed the rest of the dermatofibroma. So we rarely get to see this because oftentimes after the punch is done, unless it's a cancer or something, it's often not removed, and so the gel foam stays there until it's absorbed. So pathologists may recognize gel foam because they see it used elsewhere by surgeons elsewhere in the body, but in the skin, you will only occasionally encounter it. So that's a nice example of gel foam here in the midst of a juicy, big dermatofibroma. How fun. This is case 24, and we've kind of a shave, and we can tell that it looks kind of like skin, but it's very pale, washed out, white, clear looking keratinocytes. That's because they're filled with glycogen, and the glycogen dissolved during processing. So that plus the lack of a stratum corneum and lack of a granular layer tells us we're in squamous mucosa. And in this case, it's from the oral mucosa. And down here in the submucosa, I always want to say dermis or epidermis because I'm so used to looking at skin, but I have to remember to say mucosal epithelium and submucosa or subepithelial connective tissue, whichever name you like. When I'm in the mouth, I've got to remember to use those terms. But if you'd said epidermis and dermis, it's equivalent, right? But not technically accurate. So here we see pigment. So at first glance, it looks like brown pigment, kind of spindly looking. You might think maybe this is a blue nevus in a mucosal site. But going closer, they actually don't have quite the same spindled cells as a blue nevus. Blue nevus usually has a denser sclerotic collagen in the background, and here we have very loose, kind of edematous, spread apart, fine collagen. And then also the material here is kind of, it's hard to appreciate, but it's kind of a more speckled pattern to it. And often when you see it on light microscope, some of the little specks will look almost more black, but it can range between black and brown. And it's deposited actually, not instead of it being in spindle cells, it's depositing on little wispy elastic fibers and maybe some collagen fibers too. And some of it's being taken up by macrophages, histiocytes in the background. See here it looks almost more black and rather than brown. So this is when we see little particles that look black and are fine and are depositing on fibers. You can think about metal deposition. You can also think about drug deposits if you're in the skin and depending on the clinical situation. But here, this was probably a little gray to blue to black papule on the gum line or the labial, the mucosa of the gums near the teeth. And so this is an amalgam tattoo, and this is from probably in an older patient. I think nowadays amalgam, which is like a silver-based composite metal used for fillings, dental fillings. In the process of applying that, I guess during some of the drilling or polishing, I'm not a dentist, I don't know, so please forgive me, dental and oral pathology colleagues, if I'm explaining it wrong. But sometimes little bits of the amalgam would get kind of spun out by the high-speed drill or polishing tools and get embedded into the mucosa adjacent to the tooth. And so that would leave a little pigmented area, and so sometimes that gets removed later if someone sees it, just to make sure it's that, not a melanocytic lesion. That's my understanding. Because you can get both nevi and melanoma in the oral mucosa. So if there's any doubt clinically, sometimes that would be an easy way to sort out what's going on here. My understanding is that metal amalgam is not used much or as often anymore because there are composite materials and ceramics and other stuff that are used that are not metal based, and so I feel like we don't see these very often in modern times unless a patient's older and has a metal dental filling. So that's an amalgam tattoo, and of course the clinical information and the anatomic site is really important here to recognize this. Case 25. At first glance, you might think this is normal dermis because it looks pink, and you think, well, there's inflammation here, but the dermis is pink. There's some white spaces, probably artifact where the tissue's torn apart. But if you compare it to the other side of the punch biopsy, it's kind of cut a little bit off center here. You can actually see in contrast, this is normal dermis. The color of the collagen there, kind of this reddish pink or darker pink. And in fact, the whole dermis here has been replaced by pale pink material. There are also artifactual white spaces here, cracks that have partially separated during processing, but the dermis actually is homogeneous pink material with abundant cracks and then separation artifact. But this goes back to what I said towards the beginning of the video, that when the whole dermis is abnormal and pale and pink, if you don't have normal dermis adjacent to compare it to, at first glance, sometimes your brain just doesn't appreciate that the dermis is abnormal. And so you look closer and are like, oh, wait, that's not normal reticular dermal collagen. It's too pale and it doesn't have the right texture. There's all this crack artifact. So this is amyloid, okay? Pink homogeneous material with crack artifact. If you have a light microscope, you can flip your condenser and see that collagen is made of bundles that we can see under light microscopy. They're refractile bundles. they're little fibers. You can see the collagen fibers arranged together to make each of these big, chunky reticulodermal collagen bundles. A condenser flipped on and off on a microscope will make it even more refractile and obvious to see that there's collagen fibers there, whereas amyloid looks homogeneous because the fibers it's made of are extremely small, too small to be seen as discrete individual fibers under light microscopy. You have to look on electron microscope to see the individual, I can't remember if it's 6 or 8 nanometer filaments. I can't remember that little pearl from boards years ago because I don't use that in my practice. I don't do electron microscopy. So in any case, I find that sometimes helpful to tell sclerotic collagen apart from amyloid on just H&E is flipping my condenser. If it's so homogeneous I can't see any or minimal fibers, that's a good clue it might be amyloid. Of course, doing stains like thioflavin T or Congo red or other stains for amyloid can help. And in this case, this amyloid is filling up the dermis. It's also present, if we look on the other piece over here, around adnexal structures. There's deposits encasing the eccrine glands here. It's also encasing and infiltrating in between the fat. There's often involvement of the fat in amyloid like this. So this is light chain amyloid, most likely. I would still personally send this off for mass spectrometry analysis because I have access to that in the area where I work. So I'd send this out and get mass spec to prove that this is light chain, unless the patient had a known history of systemic amyloidosis or myeloma or a clonal plasma cell process. But the reason is because if it is AL amyloid, then the patient needs to be worked up, definitely needs clinical workup to rule out systemic amyloidosis and a clonal plasma cell neoplasm. But one clue here that this might be localized to the skin rather than systemic is that there are scattered plasma cells present in the amyloid. Where was one? Over here. There's a plasma cell, like you'll have to believe me, 1 or 2 plasma cells there. And then over on the other side, we have a nice infiltrate of lymphocytes and plasma cells, quite a few plasma cells in here, intermingled with the amyloid. So in this situation, that's a good clue that probably what we're dealing with is what's called nodular amyloidosis. I don't really love the name because systemic amyloidosis, which is made of the same type of amyloid, light chain, AL amyloid, also can form nodules and microscopically look identical. So to me, the only way to tell nodular amyloid that's localized to the skin, AL amyloid, light chain amyloid, from systemic amyloid depositing in the skin is to do workup clinically and to make sure that the patient doesn't have a clonal plasma cell neoplasm in their bone marrow and doesn't have cardiac involvement or renal involvement, all that stuff, okay? But otherwise, the microscopic appearance to my eye can look identical. So remember that the systemic amyloid and localized, the nodular form of amyloid that's localized in the skin, both can look the same microscopically. The one clue is that if you have plasma cells present in the amyloid, that's a good sign pointing to the fact that it may just be localized to the skin. But if you do mass spec, they will be identical. Mass spec cannot tell these apart. They have to have clinical workup. Mass spec will show AL, light chain amyloid, both for nodular amyloid, the localized skin type, and for systemic amyloid, okay? So I've sometimes seen the clinical team ask us to do mass spec to tell them which one it is, and I'm like, it won't tell you that. You have to do the clinical workup instead, okay? So recognizing the homogeneous stuff, the cracks, the encasement of fat, usually deposits in the vessel wall, the wall of larger vessels, deep in the dermis or in the subcutis particularly. That's helpful, but you don't always see that, especially on a skin biopsy, because the bigger vessels that tend to get amyloid in their wall are often down deep, like in the subcutis. You can kind of see a little bit here. There's some homogeneous amyloid around the wall of this vessel and this, but it's not a real classic presentation, okay? That's a good example of amyloidosis. In this case, this was nodular amyloidosis, light chain amyloid associated just with the skin without systemic involvement. I still personally think these patients should continue to have some degree of follow-up because a subset of them, from my reading at least, will potentially progress to systemic amyloidosis eventually, maybe years later. So. Case 26. This is a nodule. There's an epidermis up here, and then a big nodule in the dermis and pushing down into the subcutis. And it looks black or dark purple here. It looks black here on this scan, but in On a light microscope, it would look more purple, very dark purple. It's fragmented and fractured, so calcification. So your first thought at low power would be calcinosis cutis, multiple nodules of fractured calcium in the dermis and or subcutis, okay? And when we look closer, though, let me find the area. Very tricky in this case because it's pretty focal. But you can see here as this comes into view, gosh, it's a little out of focus. Sometimes calcified things are kind of thicker on the cut, and so it's hard to get them to scan well because they're out of focus a little bit. But here you can see it. These are sheets of dead keratinocytes that are beginning to pick up calcium. These are called ghost cells or shadow cells. And this is the classic finding in pilomatrixoma, pilomatricoma, whichever you like. You can use a C or an X. I think pilomatrixoma looks cooler because it's got the X, but pilomatricoma with the C is easier to pronounce, for me at least. But do what you like. These ghost cells here tell me that even though there's tons of calcification, what this is actually is a pilomatrixoma that has extensive calcification and probably some ossification and bone formation. It's very common to get calcification and metaplastic bone or ossification in pilomatricoma. And sometimes it can be so extensive that it makes it really mimic calcinosis cutis or osteoma cutis. And the way to tell is by finding the ghost cells, the dead keratinocytes or shadow cells that are present. And it can sometimes be very, very focal. If you called this, calcinosis cutis or osteoma cutis, though, I mean, nothing bad would happen to the patient unless they were really worried that there was a systemic problem. If it was a solitary nodule, it would probably not be the end of the world, honestly. It wouldn't be a major treatment or difference for the patient. It's benign either way, okay? But just for testing purposes, so you know, finding those ghost cells, even if they're focal, that's the clue to tell you you're dealing with a pilomatricoma with extensive calcification rather than calcinosis cutis. Pilomatricomas are benign hair follicle tumors. I've got lots of other videos about them and other examples showing you more classic findings with extensive blue basaloid cells and mitoses and giant cell reaction. But they get more common in kids, but adults can have them too. This is just an example to show you that they can be extensively calcified and ossified. So here, with the pink around it, that's probably some bone formation, actually making osteoid. Here is a punch biopsy, probably from the trunk because of the thick reticular dermis. And the epidermis looks, maybe has a little bit of hyperkeratosis, but not much, and maybe tiny spongiosis, but relatively little change. The main findings in the dermis, you can see even from this power that there's superficial and deep perivascular infiltrate of inflammatory cells, probably lymphocytes. Okay, so perivascular lymphocytic infiltrate involving the superficial vessels and focally even the deep vessels here. Okay. Interestingly, there's also a naked hair shaft, a distorted pigmented hair shaft here that's not in the middle of a hair follicle but has fallen out of a follicle or been kind of ruptured out of a follicle and surrounded by some fibrosis and histiocytes. In this case, probably that's just an incidental finding. Maybe there was an incidental ruptured folliculitis here or something else. But I don't think that's associated, but just in case you notice that, that's what that is, just an incidental naked hair shaft. In this case, not related to the diagnosis. So here we have superficial and deep perivascular lymphocytic infiltrate. If it comes into focus, maybe on this piece, you can see that they're lymphocytes. The epidermis shows no significant change, really. No good interface alteration, very minimal, if any, spongiosis. Is basically normal epidermis. And then it's hard to appreciate here because of what we've talked about, but there is some subtle increase in dermal mucin. There's a little extra space between the collagen, and if you were to do a colloidal iron stain, it would probably light up and show that this bluish kind of granular stuff that's very hard to see on this scan, there's kind of blue smudgy stuff between the reticular collagen bundles, that is interstitial mucin or myxoid material, hyaluronic acid, ground substance, whatever you like to call it, in there. So superficial and deep perivascular lymphocytes with increased interstitial mucin in the reticular dermis is a classic finding that we will see in lupus erythematosus. And in a case like this, where it looks like lupus but doesn't have the epidermal interface alteration, we would call this tumid lupus erythematosus. And tumid lupus is often a plaque, a kind of indurated erythematous plaque or nodule, or sometimes multiple nodules or plaques, often on the chest or trunk of adults, more common in middle-aged or younger adult women. And it is not usually associated with systemic lupus. So some people have argued that it's, even though we call it lupus because it has the dermal changes that are similar to those seen in other forms of lupus, because it's usually not associated with lupus, systemic lupus, maybe it's actually not really lupus after all in some other process. Some people have argued that maybe it's related to erythema annularis centrifugum or other types of skin disease, or Gessner's lymphocytic infiltrate, which is a terminology that I personally don't use. I think of it as being on a spectrum with tumid lupus, but these are the things that people have argued about in the literature for years, and you can read up on and see what you think. But perivascular, superficial, and deep with some increased mucin and no interface alteration in the right clinical setting would fit for tumid lupus, okay? And what was the other thing I was going to say? And there are a variety of other things that have superficial and deep perivascular lymphocytic infiltrate, like syphilis, and polymorphous light eruption, drug reactions, arthropod reactions, etc. And you can go and watch my other video about inflammatory dermatopathology 101, which talks about some of those inflammatory patterns. So that's tumid lupus in this case. But lupus, especially tumid lupus, often does have quite a bit of interstitial dermal mucin. But that by itself is not a specific finding. You can see mucin in other things aside from lupus. And also I've seen cases of lupus that lack or have very minimal interstitial mucin. So it's not a specific finding, but it is classically taught as being present. And I would say that in tumid lupus it usually is present. It's usually abundant. But it's kind of hard to see, especially on a slide like this. Now here we've got a nodule from deep soft tissue, and there's no skin here, so this is probably subcutis or deeper. And you can see even from this power, we've got these unusual, irregular kind of lakes or islands, I don't know what you want to call them, of bright pink material, and it's surrounded by a cellular aggregate kind of making a rim around these islands, okay? So when we look closer, what we have is that the center of these islands are pools, are red, kind of amorphous but vacuolated material with very little cellularity, and it's basically fibrin or fibrinoid necrosis, you could make an argument, kind of dead collagen and fibrin mingled together. It depends on what you want to call the diagnosis as to what term you use, in my opinion. This looks a lot like fibrin, but I would argue there probably are some dead or degenerated collagen bundles in there. So some people might use the term fibrinoid necrosis for this. I think that's probably what I would say here too. And what it's surrounded by is a rim of plump histiocytes. So kind of a granulomatous infiltrate around this core of dead fibrin and dead collagen in the middle, okay, with relatively little inflammation. And if we look closer, these are plump histiocytes. They don't have significant atypia. So this is the pattern. What we're seeing here, the pattern we're seeing here is palisaded granulomatous dermatitis, or palisaded necrobiotic granulomatous dermatitis, excuse me. So palisaded necrobiotic granulomas, which means these big pools of degenerated material surrounded by a dense layer of palisading, kind of layered histiocytes, is a pattern that we see in a couple of different things. We can see it in rheumatoid nodule and deep granuloma annulare, okay? So the classic teaching is that rheumatoid nodule is a red granuloma. It has bright red, more fibrin-rich deposits in the center of the palisaded necrobiotic granulomas. And deep GA, deep granuloma annulare, tends to have mucin or myxoid material, so it's more blue and looks like a blue granuloma. Okay, I would say that in real life, though, it doesn't quite work out that way so often. So if you were to show me this on a test and say no clinical information, what is the answer? I would tell you this is a rheumatoid nodule probably. But in this case, per the per the answer sheet here, and again, this is a very old case and I don't have the clinical history, but the clinical history evidently supported that this was not rheumatoid nodule, the patient did not have rheumatoid arthritis, but instead this fit better for deep granuloma annulare, deep GA. So it doesn't always work out, and some people have made claims that you can see some fibrin in deep GA, but you shouldn't see mucin or myxoid change in rheumatoid nodule, but I feel like I've seen exceptions both ways. So just know that classically, if it's red and it's palisated necrobotic granulomas, rheumatoid nodule is the classic finding. But if it's blue mucin, or if it's got dermal changes that look good for regular granuloma annulare, then it would be more likely deep GA. The way I handle this in real life, especially if I don't have clinical information, is I would say here, palisated necrobotic granulomas. See comment, and in the comment I would say that the findings look like rheumatoid nodule, but if the patient doesn't have a history of rheumatoid arthritis or doesn't have signs and symptoms of rheumatoid arthritis, then the other possibility would be a deep GA. And in my experience, infectious granulomas very rarely produce a pattern like this. But I have seen one rare case that ended up being an AFB infection, and that had a look very similar to rheumatoid nodule. It's been so long I don't remember exactly, but I remember thinking it was going to be rheumatoid nodule. So I don't always think that it's required to do infectious bug stains on every case of deep GA or rheumatoid nodule that you see. In fact, a lot of times I'll say a comment to the effect of I wouldn't favor an infectious process, but if there's clinical concern, they could biopsy for cultures. But if you want, you can do infectious stains on these. I feel like you could have different views from different people, but it is quite time consuming to search for infectious organisms in a big specimen like this. And so you have to kind of think about feasibility and the caseload that you have to take care of to make sure you get all your patients taken care of in a timely fashion, and also what your pretest probability of infection is depending on the scenario. So that's my thoughts on that, and you can think about that and decide what you want to do. I would also say a couple other things is that rheumatoid nodules in patients with rheumatoid arthritis, you'll often see lymphocytes and plasma cells around them. That can be a helpful clue. And also they often have some scattered neutrophils, and nuclear debris is often present in rheumatoid nodule. I feel like it's less common to see those things in deep GA, but again, none of those things are totally specific. So they really have to fit it with the clinical scenario. But this was called a deep GA based on the clinical information in this case. But I would say that honestly, you could put this in a picture in a book and say it's a rheumatoid nodule, and it looks perfect for that. The one important thing before we go on to the next case to point out is that, rheumatoid nodules often arise over joints, elbow particularly, or the joints of the hand. In patients with rheumatoid arthritis, not all patients get them. Who have rheumatoid arthritis, they're often soft. They're clinically often recognized as rheumatoid nodule. Deep GA tends to be more common in younger patients, particularly kids, and may present as one or more subcutaneous nodules, often on the lower leg of a child. But kids can get rheumatoid arthritis also, so it's important to keep in mind that even though if it's a kid, that rheumatoid arthritis could still be in the differential. It just depends on the situation. But the last thing I wanted to say is that the one bad thing that you want to always keep in your differential for a palisated necrobotic granuloma is epithelioid sarcoma, because it can produce a similar pattern that resembles closely, sometimes from low power, closely resembles rheumatoid nodule or deep GA. But when you look closer, what you'll see is the cells around the edge are not actually plump histiocytes, but instead they're very large nuclei with pale chromatin, very atypical appearing, and have abundant dense pink cytoplasm, and they're actually malignant cells. And if you have any doubt, you can do stains like keratin and EMA, which are going to usually be positive, and also INI1 or SMARCB1, which is going to have loss of nuclear staining in the majority of cases of epithelioid sarcoma. So it's important to remember that, because it can also present as a nonspecific nodule on the distal extremity of a young adult, just like a deep GA or rheumatoid nodule could. So important to always keep that in mind in your differential, and look around at these cells and make sure they don't look malignant. And if you have any doubt, you can do immunostains to sort that out. I have many videos about epithelioid sarcoma. It's extremely rare, but it's an important mimic to always make sure that you don't miss when you're thinking about rheumatoid nodule or deep GA. Now this is case 29, the final case. this is subcutaneous fat with no skin over it. It's a fat pad biopsy. When there is a clinical suspicion for amyloidosis, systemic amyloidosis, it's desirable to prove it with a biopsy. So the question becomes, especially if the patient doesn't have obvious skin lesions, some patients with systemic amyloid get periocular hemorrhage, or they get other skin abnormalities that are suspicious for amyloid, but some patients don't have any obvious skin abnormality. So then the question is, we need to biopsy some tissue in hopes of finding some amyloid deposits. So the area that's often suggested the biopsy is the abdominal fat pad, the subcutaneous fat from the abdomen. Sometimes people will do fine needle aspirate or deep punch biopsy, like a double punch. I would argue that ideally the best way, if you really want to rule out amyloid and you have a high suspicion clinically, is if you're going to do a fat pad biopsy of the abdomen, do an incisional surgical biopsy and take out a good sized chunk of subcutaneous fat. Like this piece here is probably, I don't know exactly how big this was, but this is probably a centimeter or 1 to 2 centimeters across, piece of fat from an incision. And the reason for that is that the amyloid is not, you can't tell where the amyloid will be deposited. It's not uniform, and you may get focal deposits in between the adipocytes. You may get focal deposits in the walls of vessels. Ideally, you want to see the subcutaneous fat, and you want to see some thick-walled vessels. And the more of that you have, the better your chances are of making sure you find amyloid if it's there. So if there's only a tiny chunk of fat, I may not see any amyloid, but am I sure it's not a false negative? I'm not. So here's a good example. Look at this. The fat here really looks pretty much normal to me. That fat looks totally normal. Over here, look at all this stuff. This is amyloid in here. There's some amyloid deposits. The bright red here is blood, but there's some amyloid depositing in here, in between collagen. Sorry, the darker red here, these are collagen bundles. The pink here, in between, not light pink. I misspoke. I'm sorry. The light pink here is the amyloid, and then for contrast, those are some thick collagen bundles. And then here in the vessel wall, there are some cracks and some pink. So right there, right at the edge of this muscular wall of this vessel, that's probably some amyloid there. I'm not totally sure, but it's suspicious. Let's look over here. We got a different view, the vessel was kind of cut at the very edge there. Here we're cutting right through the middle of it. And there's some pink stuff. That could be amyloid. I'm not totally sure. So it can be in the wall of vessels, and it can also be in between the fat or in between the collagen. So when we get these specimens, we usually routinely do a thioflavin T stain. Some people would do a Congo red stain. It depends on what works best in your lab, what you have access to. That right there is looking pretty suspicious. There's cracks and pale pink stuff. That's kind of homogeneous in the wall of the vessel. That looks suspicious for amyloid to me. So I think we have a stain here. So this is Congo red. So in this case, Congo red, here's the control tissue, which was from, I believe this was kidney. Oh, I'm sorry, I may be telling you wrong. If this was Congo red or, yeah, this was Congo red, not amyloid P. Here you can see the perivascular deposits of homogeneous amyloid with cracks, densely staining. Usually it looks kind of a bright or a salmon pink color, but here it's kind of looking more orangey, and it may just be the staining quality here or the scan quality. I also wondered if this could represent actually an amyloid P stain, but in the answer sheet it's labeled as being Congo red. But Congo red usually looks more of a pink color than this. Problem I have is that Congo red it seems to be kind of variable and has high background staining sometimes, so it can make it hard. And unless you have a bright enough light source on your scope, getting the apple green birefringence that everyone teaches you about in med school, getting that to work properly is quite challenging, I find. And normal collagen will have kind of a yellowy green birefringence automatically to it, and so it can make it really hard, in my opinion, to tell real amyloid apart from background collagen. So that's why I've really found the thioflavin T to be better in my experience. So try it out if you want. So here we can see the deposits in the vessel wall. They are staining here on this amyloid stain. But it's kind of hard. Look at the muscle. The muscle also looks kind of dark. I agree this is darker, and the muscle is lighter, but it's a challenging stain to interpret because of the background. And it's, I think, the same thing over here, where you're seeing dark staining here that looks different from the collagen. But it's hard, I think you probably would agree with me, it's kind of hard to sort out. And the last point is that it is focal. It is in the wall of the vessels here, like kind of wrapping around the outer wall. But in the fat in between, there's not really any amyloid. This is, I would argue, this is negative here. So that's the reason that it's important to get a big enough sample, ideally to get a thicker muscular walled vessel if you're doing a fat pad biopsy for amyloid, because it can be quite focal sometimes. And the last thing I would point out that was something I didn't recognize until well into my training is that sometimes you can get extensive amyloid deposits in the abdominal fat, where you look at it and it's obvious amyloid. It's a huge sheet of amyloid encasing fat, wrapping vessels, everything. And sometimes it presents as a mass clinically and it'll get removed as ruled out lipoma. So it's not like this. It's like the best ever amyloid you could imagine, not this kind of subtle focal finding. But that kind of amyloid is, you can see there when it makes like a big mass of extensive amyloid deposition. You can see that in the abdominal fat of patients with diabetes from insulin injection. And so it's insulin type amyloid. And that's from chronic insulin injection in the same areas of the abdomen, and some of that insulin accumulates and deposits protein, and if you do mass spec on that, they will actually show that it's insulin type amyloid rather than light chain amyloid. So I think it's important to know that, because the first time I saw that I was like, whoa, this is insane amount of amyloid. And then we checked in the patient had diabetes, and on mass spec it was insulin type amyloid rather than light chain. So I've now seen a handful of cases of that. Sometimes where it was clinically thought to represent a tumor, a lipoma, or some other tumor because it was such a big nodule in the abdominal wall. And microscopically, it was extensive amyloid deposition, but it was the insulin-type amyloid, which is not associated with any systemic amyloid deposition. So I think that's something to be on the lookout for if you've never seen that before. It was really impressive. The cases I've seen of that were not subtle, to say the least. They were extensive. So just so you know, that's one other thing you could find in the abdominal fat that's amyloid, but not associated with systemic. So if you're still here after 2.5 hours or more of all these deposition diseases, I applaud you, and I hope you've learned something along the way. Thanks very much for watching. Have a great day.